All right, I think we're going to get started because we have a really jam-packed schedule. It's going to be extremely intense. So make sure you eat up and get a lot of food and fuel for the afternoon. My name is Dr. Cynthia Tsien. I'm a liver transplant doctor who works at the Toronto General Hospital in Toronto. Um, I'm really hoping that we have like a really warm, collaborative time. Like, I know we're at a podium and we're lecturing, but really, this is an opportunity for all of us to eat together, talk to people who are maybe going through some shared experiences, and to really be able to ask questions, meet us. We have a lot of healthcare workers from Toronto here that you may be seeing in the future or you've met before. Feel free to come up, chat with us, and we really wanted to come and give you guys the opportunity to meet with us, talk to us. We can learn from each other. So really, even though I'm at a podium, this is not formal. Feel free to put your hand up, ask questions. The food is out until 1:30, so feel free to eat. I told you guys earlier the cookies are not low sodium, so again, that warning, if you're low sodium, don't eat the cookies, but otherwise everything else is good. And we have patients here who have liver disease and kidney disease, but I think everybody is going through that journey of unfortunately end stage organ damage, needing to have a transplant. So a lot of the talks at the beginning are applicable for people with both liver and kidney disease. And then afterwards, at the break, we're going to split into a different room. So patients who want to learn more about, or families as well, and healthcare providers, anyone who wants to learn more about liver disease, if they could go to Scandia 3, and we'll remind you again before the break. And then patients and families and healthcare providers who want to learn more about specific kidney disease are just going to stay in this room. So the only other thing I wanted to say was that we really do encourage sharing and asking questions. The only thing I would ask people is to remember that we cannot give specific health advice. So if you want specific answers about your particular health conditions, it's best to speak to your healthcare provider who's taking care of you. Otherwise, I think we're going to get started. And I just wanted to start by acknowledging that we are meeting today on the traditional lands of the Anishinaabeg Nation and the traditional territory of Fort William First Nation. And really wanted to acknowledge the history of colonialism in Canada. And this is just one small way that we really wanted to acknowledge the racism and structural racism that occurs still in Canada and Ontario. And we really wanted to come meet with people and acknowledge that our healthcare system is flawed in many, many ways, but we really want to change things and um, we want to listen to other people's experiences, acknowledge the challenges, structural challenges that take place for people accessing the best care possible, and to work with you guys to really try to improve things. So without any further ado, it's my distinct pleasure. I'm the only one with the schedule, so I'm the only one, no one who knows what's happening, but I'm very pleased to introduce Kamika, who's going to be talking about advocating for your health, and she will give you more info on herself and her mission. Thank you so much.
Okay, good afternoon, everyone. It is going to be a jam-packed day, but I'm super happy to be a part of the team speaking with you guys. The healthcare journey, as you know, whether it's liver transplant, kidney transplant, or any condition, can be very frustrating. It can vary depending on a number of factors. So we're going to talk about how can we actually take, matters into our own hands? What can we do to advocate for ourselves? And how can we own our health when it comes to navigating the healthcare system? So we're going to talk about different experiences of marginalized groups and what racism looks like in healthcare, as well as how do you overcome the fear of seeking care when you've had negative experiences. There are oftentimes breakdowns in trust when you have those experiences. And how do you actually get through that and overcome that so you can actually participate in your care? And last but not least, we're going to provide tools, resources, mostly online resources that you can look into to help you on your journey. So that is me on a way better day than today. I am a travel nurse. I have been, well, semi-retired travel nurse. I've worked across Canada from coast to coast in some very rural areas and also urban areas. I'm from Alberta, British Columbia, Nova Scotia, and Ontario. So I have seen quite a bit. And in addition to my work as a nurse, I founded a nonprofit in reproductive health, specifically in women's health, that's looking at doing research and advocacy for Black folks who are giving birth in Canada to ensure that we're not having, harm and negative outcomes. I'm also a health tech founder. So I'm looking at burnout amongst healthcare workers and how can we actually use AI and different strategies to essentially mitigate burnout and keep more of us at the bedside doing what we love. I'm also a health equity advocate. And I promise the final thing that I am is also a patient. I've been diagnosed with like a rare condition and have multiple, we'll say, health challenges that I'm navigating. So I know what it's like to have 5 specialists and 10 appointments and can't keep track of what's going on and what medications they're putting you on. So it definitely is challenging and shifting from being a nurse who's providing care to now being, laying on that stretcher or in that chair, speaking to your care team. So I feel like my experience and all the work that I've done as a nurse and as a patient has truly allowed me to learn how to navigate the healthcare system. And I try to do that, teach that for others. So, I'm gonna get you guys to, if you could describe your healthcare journey. Some of you guys are healthcare providers, some of you are here for your loved ones. If you could describe your healthcare journey in one word, what would it be? And I can start. I would say interesting for mine. Does anybody else want to just shout out a word? Please no bad words for today. Um, maybe like after the break, but it's still kind of close to morning. So any words that you would describe your health? Bumpy, okay. Challenging, scattered, yeah. Frustrating, yes. Anything else? Overwhelming, yeah. Notice that no one has said smooth, consistent. No one has said fantastic, cohesive. So those are the words that I would hope that in the work that we're doing and even coming today and doing sessions like this, that we can actually move towards a healthcare system that is less disjointed and more cohesive and truly provides the care that each and every person in this room and the loved ones who are represented and those who are online deserve. So how do you when you have breakdowns in trust, how do you actually mitigate that? So, like we were mentioning before, there's a history in this country of medical racism. The research oftentimes doesn't it reflect different groups, and we see breakdowns in care. And unfortunately, even though we strive to do our best and to not do harm, harm does happen in the healthcare system. A lot of times people have bias, stereotypes, prejudice against different groups, and sometimes we don't leave that at home and we bring it into the patient's room. And when that happens, oftentimes patients feel a mistrust, they feel sometimes shame, and sometimes they won't even seek care based off of those lived experiences. So how do you build trust when that happens? And how do you support people that are experiencing that if that wasn't your experience? Well, first and foremost, and I put asterisks there because I know that in some communities it is a challenge to find a healthcare provider. We have I think, a crisis with primary care right now. So looking for a healthcare provider that understands your needs can be very difficult. So one of the things that we've done is we've come to you, right? We've come to speak to you about the ways that UHN can support on your respective journeys, but having that willingness to have a conversation, to truly allow them to see you and create a relationship with your healthcare provider is really important. And when that's not possible, because I've worked in some communities where there's one doctor for the entire community, so you kind of are in a tricky situation. So that's where I give you strategies on how do you make the best of a not ideal situation. And asking questions and standing firm in your care. I tell all my patients that we are not dictators, we are partners in your care, but you are the one that's in charge. Your autonomy is the most important thing in making sure that your care reflects what you would like your care plan to look like. So, advocacy is as easy as ABC. I start with adjusting your attitude. Even when we've had these negative experiences, like I said, mentioned before, oftentimes our goal is to not do harm. So I encourage all my patients, and even like with your loved ones who are going through this, go in with an open mind, truly give the benefit of the doubt, but still be vigilant, still ask the right questions, but truly go in with giving them an opportunity to support you in your care. The B is for bring back up. Some of you guys are supporting your loved ones, and I don't know about you, but I have the memory of a goldfish. And in some of these appointments, when they're telling me terms that I've never heard before, procedures, risks, and all these things that are very important for me to make a decision in my care, I can't remember that because maybe I'm sick. Maybe I'm stressed about this whole process. So having somebody else there, a second set of eyes, a second set of ears, and also someone to hold your hand through the process, someone who knows what you're going through, and someone who knows what are the desires for your care so that they can also advocate for you. The C is for concise conversation. Sometimes patients, and I'm guilty of this, we have word vomit, for lack of a better word. I have patients come into the ER and they're like, my leg's been hurting for 20 years and my back started hurting last month and now my right eye twitches. And I'm like, I do not know where to start, but we will try to address your needs. But I have a tool that we'll share for patients to really organize their thoughts, put their symptoms down, get all the most important information. So when you're walking into an appointment with a physician or a clinician, or consulting with different care team members, you actually can provide them with a concise overview of what is going on so that they can truly help you and make recommendations for you. And D is for detailed documentation. So sometimes when things don't go right, it's important to have documentation, but also when you're experiencing, healthcare challenges and then being put in situations where you have to make decisions, right? Living donor or not, kidney transplant, there's so many different things, liver transplant, that are involved in decisions that have to be made. And sometimes you can't keep track of all the things that they told you. So having documentation or just stopping, whoever you're speaking to and saying, are you able to write that down for me? Or can I get a printout of this so that you can truly listen and not be worried about trying to retain everything and then have paperwork that you can also share with your loved ones when you come back from your appointments so that you can collectively make a decision together. So we have our ABCs, we're working on building trust. How do you overcome that fear? Sometimes when you walk into that room, it might be a different provider, it might be a whole different hospital or even, room, but you still carry that fear from the last time that you were dismissed, the last time that you didn't felt seen, you never felt seen. And it's okay to feel nervous, but I truly recommend that if you've had a bad experience, that once again, we adjust our attitude, we chat with them, we let them know, hey, this is something that has happened. This was a concern in the past, so that then we can be sensitive to it. We can acknowledge what's happened and then try our best to make it right. We can't always go back in the past, but we can try to have a better future. So bringing somebody with you, writing things down, and remembering that you deserve respectful care. You are entitled to dignity just for being a person. It doesn't matter how you look, doesn't matter how much money you make, it does not matter if you've experienced mental health challenges or any things that are often stigmatized, you are deserving of respectful care. So, how do you prepare for these appointments? So the plan was to actually give you guys like little wallet cards, but I wasn't able to get them done in time, but hopefully we'll be able to share with you. So we have a tool called SBAR. So I've kind of taken SBAR and changed it to preparing with care. So this is like my framework, even when I'm going into appointments or going into the emergency department, so that I can actually provide my healthcare provider with information that is concise and lets them know all the important things about me. So first, the C is for concerns. What is the reason that you're there? Are you there to consult with your nephrologist? Are you there to, maybe you're in the emergency department, or maybe you're at your family doctor? But what is the reason that you're there? Are you looking for, them to diagnose something new that's going on? Are you there for a follow-up? Maybe you want a CT scan of your abdomen for ongoing pain. Essentially, just what is the reason that that you're there that day? The A is for your account. So let's look back at your history. I'm sure many of you know that your history is very important. The medications that you're on, even your family history of things. If you've had significant medical events like hospitalizations, if you've had surgeries, right? So these are things that sometimes we forget to mention. And unfortunately, I've seen cases where they forgot to mention something very, very important and the outcome was actually life-threatening. And because I was working in a rural community that didn't have electronic charting. So that was on a paper somewhere that we never saw. And essentially, if it was caught a lot sooner, I think the outcome would have been a lot better. So if you can now keep track of these things, I know it's difficult, but just it's important that you have your history, your healthcare history. And I recommend patients have a healthcare diary or a note on your phone. I know there's a lot of apps coming out, but I think a lot of us are tired of all the apps and the passwords to remember. But having a diary where you can keep track of all this information can be very helpful. The R is for review. So summarize what's happening, right? If a patient comes in and tells me, my stomach has been hurting for like 3 months now, that's not necessarily the most doesn't provide me with all the pertinent information versus a patient who says the right side of my stomach has been hurting for a month now, and every single time it I'm vomiting as well, the vomit is green, essentially providing me with more information that I can now we can look at differential diagnosis, we can actually look at what tests would be appropriate, but it helps guide your care in the right direction. And, pictures and videos are helpful. I think sometimes, and my context is emergency department, so that's where I speak from a lot, but sometimes when you get to the emergency department, the thing that brought you in is no longer happening, right? I have parents bring their kids in, and they're like, I promise you my kid was sick before I got here, but after waiting in the ER for 3 hours, now they're playing with their toys and they look fine. But taking pictures sometimes, like if they threw up or if, maybe you had abnormal bowel movements, I'm so sorry. But taking pictures sometimes can be helpful, so that we can then make better decisions about your care based off of the information. And then E is, what are your expectations? Are you going into that appointment? Are you looking for a recommendation? Are you looking for a referral? Are you looking for certain tests, medication adjustments? What do you think is happening? Maybe you have a family friend who experienced something similar and you think it's happening to you. But I think a lot of times patients don't place importance on their own voice. And sometimes that's because there's a power dynamic between patients and providers, and we oftentimes think, what the doctor says is the most important thing, but you've been with your body the longest. You are an expert of your body. A lot of times we're just meeting you for the first time. So what you think is going on is very important. So please, think about what are your expectations. So how do you build confidence to even prepare with care? So speaking up and getting used to advocating for yourself isn't easy, but when you're able to clearly, articulate what's going on, when you have a plan, I think a lot of us feel more prepared versus going in and winging it, right? Asking questions. Oftentimes, patients will go into different consultations or encounters, and they won't ask questions until they get home, and they're very like apprehensive about what's happening. They don't have all the information to make a decision yet, and things can get delayed, or they might maybe agree to something that they don't feel comfortable with. because they didn't ask the necessary questions. So definitely recommend asking, are there any alternatives? What does this mean for my health? What will this mean for my lifestyle? How will this affect it? I think when we're making big decisions like thinking about transplant, there's so many things that are involved that will affect your life and your loved ones. It's very important to speak up and ask questions. Like I said before, keep notes and access resources in your community. So what are some of those resources? So sometimes when things go wrong, it's important that we have methods and ways to hold people accountable. So the patient ombudsman is one resource. There's a lot of us belong to regulatory bodies, so like colleges that we are accountable for our licenses. So it's important that when there are things that go wrong, we hold people accountable so that it doesn't happen again. I have the Canadian Liver Foundation. There's also like Kidney Foundation, and you're going to hear more about those specific resources for those specific organs and transplants. Med Visit, that is for the Greater Toronto Area. I wasn't able to find one for this area, but they have like OHIP covered doctor home visits. The Ontario Telemedicine Network, so that provides patients with access to virtual care. And healthline.ca is probably one of the greatest things that I've seen when I used to work for Ontario Health. It is a huge, I guess, repository of resources for both medical and social health services for Ontario. So you put in your postal code, whether you're looking for family services, meals for the elderly, doctors, reproductive health, anything that you can imagine, legal services, it is on there and is often kept up to date. So Thunder Bay falls in the Northwest region, and usually this is aligned to the different, I guess, Ontario health bodies for the different areas. So I highly, highly recommend that if there's any resources, because obviously my list is very short, I promise you, you can find that. And if you don't find it, you guys have my emails. You can find me and I will find it for you. There's the Indigenous Primary Health Council that connects Indigenous folks to health centers and community programs that will truly support them and understand their lived experiences. So we've talked about a lot of things. Let's sum it all up. The ABCs of advocacy, use those to, when you're overcoming fear, the SBAR tool or the CARE tool to help organize and prepare for your appointments, and then access resources. Because when I is replaced with we, even illness become wellness. We are a community here to support you. We understand that this is a challenging process. You guys all described your health with words that are not ideal, so we know that it's challenging. So we're here to wrap you guys around with support, and we really hope that on this journey you will feel supported and that we will do what we can to ensure that we have the best possible outcome. Thank you so much, and I hope you enjoy the rest of your day. Do you guys have questions? Okay. Oh, and there's questions online too. Okay. I have a question. Yes.
I just wanted to, the, on the screen you had carried,
Hmm.
this may not be really related, what I'm going to say. Okay. 48 years, I've witnessed a lot of things. My renal department. I go 3 times a week.
Mm.
and I'm there pretty well, on time. And, when I'm due to do it. Now, I wish that care thing you talked about.
Thank you.
But you talked about, applies to, to the staff, to the nurses. I see a lot of different treatments on different people, different persons. You know, I'm an Indigenous person. I see all nationalities in there. I mean, different people.
Mhm.
And these nurses, you know, I wish there was only one attitude, but
Yeah.
there's a lot of different attitudes. They treat patients differently. When I see that against me, I certainly voice that to the manager. Because it's not fair.
Mhm.
You know, there's all kinds of, advertisements to how these patients should be treated and all that. And, the bottom line is to respect. But I don't see that sometimes,
Yeah.
you know. I know it's not really related to a question. I just wanted to say this to get this thing out of my chest, you know, and because it's important. A patient is a patient, regardless who you are, you know. And I've seen, you know, people who are diabetic seem to be gone sooner than the rest, kind of thing. At least for now, I'm not diabetic yet. Maybe I am, but I don't know. But it seems that I don't know how they can get over, the my question, I guess, is that, like, I went through a series of tests, health tests and all that, to try and be on the list for transplant. And I have not made it yet. And but it seems that people that are on diabetic don't seem to have a chance to, to be on the list. I don't know if I'm correct or wrong, but hopefully somebody can answer that, because a lot of people who are on dialysis, are diabetic. And I see over the 8 years, those people gone so fast, I know maybe they don't eat right as well. Sometimes it's a fault of the economy or, their income. If you're living on Ontario Works, you can't survive with being on, on dialysis, with the right food, It's a good thing that I worked for 40 years and paid pension and, as my source of income now, along with the old age pension, Merely enough, but gets me by, At least, I can go have a steak somewhere, maybe once a week, that type of thing, that whereas others can't do that.
Mhm.
I just want to let everybody know this. My experience has been very, very, to know these things here that I didn't know either before I was on dialysis. So with that, I think I apologize for not, giving you a direct, question about your presentation. But I just wanted to let people know here that are here, you know, these things here. Because it's important, just because I'm a minority doesn't mean that I'm not, should be treated differently,
Yeah.
So with that, I want to thank everybody for taking this time here to listen to me. That's
Yeah, thank you so much for sharing. I think that what you shared is actually 100% directly related to what I was just talking about. Your experience in our healthcare system, unfortunately, is not unique and it shouldn't be what is happening all the time. And healthcare providers, like, I'm so glad that you actually speak up when you feel that you're being discriminated against, because if more patients spoke up, hopefully that would happen less and less and less. In terms of your question about the kidney, I think it was like the transplant and diabetes. I think that'll be addressed. Or like one of the physicians who is going to be speaking later, they can, speak to that a little bit more. That's a little bit outside of my wheelhouse. But I really want to just commend, like, one, the fact that you were able to stand up and share that with everyone. That reflects the confidence that we were talking about, right? To let people know that this is important and that a patient is a patient, regardless of who they are and what they look like. So thank you very much. And I do hope that you do get closer and closer to like being on that list and, getting to your end goal on your healthcare journey. So thank you, everyone. We're gonna, I think, move on to our next presenter, but thanks.
Thanks so much. I think that's actually a really great segue for Leona to come and talk about her own experiences. So I'm going to invite Leona to come up.
Hi, my name is Leona Kakepetum. I'm from Kiwewin First Nation. It's a little isolated community in northwestern Ontario where there are no road access. You have to fly in. So currently I am the Director of Indigenous Collaborations, Equity and Inclusions at Thunder Bay Regional Health Sciences Center. And I'm also a transplant recipient. I had a double pediatric kidney transplant in 2016. I was diagnosed needing dialysis in 2010. It was very, very sudden. I was out here for college. While I was in the community, outside physically, I was healthy. There was I didn't experience any symptoms, or I didn't present as being sick or any types of sorts. I was in the police foundations program, where one day I just couldn't breathe laying down and I had to go for emergency dialysis. In the community where I'm from, we have a small nursing station that is run by Indigenous Service Canada nurses. So they do rotate on occasional. So it's a hard time to create a relationship based for patient to physician or nurses. Like once you get comfortable with a physician or a nurse, and then someone new comes in. So it's like always rebuilding relationships like that. There was also no preventative education at the time in my community. Once I was diagnosed as needing dialysis, going home was also a very challenging situation. I had chosen to do PD dialysis, where I would do at-home dialysis in community, where I would have to hook myself up to a machine and every day, so that I did chose the one where I could sleep with it during the night. But there were also challenges with that too. there are a lot of differences between in community and urban settings, where in urban settings, your equipment or medications can be delivered directly to your house. They can be nicely set up in one location for you by the delivery person. Whereas in the community, they're just dropped off at the airport, sometimes on the tarmac, where you, as a patient, would have to go and physically take it for yourself. Which is also a concern where there's possibilities for patients to develop hernias because they're not allowed to lift equipment that high. So that is just like one of the major gaps within First Nations health within Northwestern Ontario. So I couldn't really live in the community where I had to move outside. So I stayed out here in Thunder Bay. My community wasn't equipped to or had the education to properly take care of me. If the power went out, they didn't know what to do for me on how to warm up my solutions. So at the time, I did have to move out of there. My community felt it wasn't safe for me to continue living in community, so I did have to come out. So while I was out here, I eventually had to go back on hemodialysis. At the time, as the elder back there mentioned, there isn't proper food that you can purchase up north. They're all run by most of them have northern stores, which have boxed or canned food. Any fruits and vegetables that do fly up there kind of goes bad quickly within the week. So it's very, very difficult to eat healthy up north. Some communities try to do their own gardens, but then that also attracts, bears or other animals that can come into community. My grandfather tried to do a garden out on one of the islands, but then again, it's difficult to go back and forth. So being a transplant patient as well, I've had numerous friends and family, even one of the ISK nurses, take tests for me to be a donor. Unfortunately, because of the health in Northwestern Ontario and the communities, there was no one compatible for me to be a donor. A lot of First Nations in the communities do have several health issues where they aren't healthy enough to be a donor, or they're worried for their own families. Like, what if my own family or daughter, when they grew up, they need like one of my organs? So a lot of people are thinking long-term in that aspect. And unfortunately, there are individuals that aren't compatible for transplant. They have other health issues as well. So being on the transplant list is a dream for some people. So a lot of the other gaps as well that I do want to mention, because we hear a lot of presentations here in Northwestern Ontario from the southern communities or urban settings. It's very, very different, as you can tell, the geographical locations. It's different from Toronto settings than it is in Northwestern Ontario. The decision makers are in the Toronto urban setting area. But they haven't come up to the Thunder Bay, Dryden, Sioux Lookout, Kenora region, or even Sudbury or Timmins. I've also worked for Anishinaabe Nation, political territorial organization for Indigenous. And I've also worked for my tribal council as well in the health field. So we are still working as Indigenous to have equal care, just to reach a level of people in the urban settings as well. So transplant, when I did get the call, it was very, very sudden. It was urgent. It's actually a funny story. So when I did get the call, I think it was the guy's first day at work. It was his first call to give the message to a patient. So he called me really quickly and he just asked for my vitals. I thought it was my nurses because my nurses over at the transplant clinic at the Thunder Bay Regional, they would often call me for my vitals. So I thought it was them. So he called back suddenly and he's like, "Oh, are you able to go to the airport in 30 minutes?" I'm like, "Sure. Where am I going?" Um, and then he was very excited, and that's when he told me. I kind of thought I was dreaming, because I was almost 7 years into my dialysis. At the time, my hair was falling out. It was very difficult for me to walk. I had issues with my calcium, my bones. I wasn't sleeping well, so I had anxiety, I had restless leg syndrome, and just getting that call, I thought I was dreaming. So at the time, I didn't have anyone to come with me. My mother was in a different town, so I did have to go by myself. Um, and the other thing too is what we have to navigate as Indigenous people is reaching out to no, NIHB, which is non-insured health benefits. Sometimes we're eligible, sometimes we're not. If there's flights, then you can get on. Sometimes there's missed appointments. We were just on a call this morning with NIHB trying to see how we can work together to fill in the gaps. But there is that jurisdictional issue as well with provincial and federal services that do have to work together. And unfortunately, sometimes we fall between the lines. And as an advocate, I didn't intentionally want to be an advocate. But that's what I did turn into because at the time there was no one to help me during my health journey as from being diagnosed to being on the journey of dialysis and then transplant. There wasn't as many workers in the hospital. We had two Indigenous patient, actually one at the time, patient navigator. She's been there a long time, so she was helpful. I was I was hesitant to work with the social workers at the time because social workers in Indigenous communities, they're not really looked at in a positive manner. But now working at the hospital, where we have about, I want to say 8 Indigenous care coordinators on top of the Indigenous patient navigators working in outpatient units that we are trying to help the Indigenous patients as well because it was something that I was needing back then. And back then I was labeled as a behavioral patient because I was trying to advocate for myself, and that's not something that we want our Indigenous patients to be stuck with on their files. Because we do want their voices heard and we do need more advocates within the area. I do want to mention that the transplant team here at Thunder Bay Regional was very, very helpful. I probably asked so many questions. Um, at the time I was young, I didn't know anything at all. But they were very, very helpful. They kept me on top of my appointments. Even to this day, I had one yesterday, so it's still every 3 months for me for transplant clinics. I hope I kind of gathered everything into what I wanted to present. I did wanted to highlight gaps for Indigenous patients. I probably left out a few things. But I do want to highlight that it is like working with the renal team and also with the transplant team for patients is something that we're aiming to advocate for as well. So I don't know if anybody had any specific questions for me. I also have a table out there for our services at the regional. We do have a booth with more information there if you wanted to give us a call or, just share information out. We also have the transplant clinic information out on the table as well.
Thanks so much. That was very powerful for you to share that with us. So we really appreciate it. Our next speaker is going to be Sasha, who is a social worker at Toronto General Hospital. And before she comes up, I'm going to say the buffet closes at 1:30. So if you want any dessert or more food, please help yourselves.
Okay. Oh, there. Okay. Hi, everyone. I'm Sasha. Feel free to keep eating as I talk today. Just a little about me. I'm a social worker with the Toronto General Outpatient Team. I work specifically with the alcohol liver disease program, but today I'll be speaking about general transplant and liver and kidney. So I went to school for my bachelor's and master's in social work. I've worked at Toronto General for a little close to 10 years. I've worked in many different areas on the medical and psychiatry units. The most important part about this slide is my dog, Penny, like for everyone to know her. So today we'll be talking about a few different topics. I'm going to tell you a little bit about what social work does. What does the assessment process look like? Some key takeaways about, what's needed for transplant patients and their families. Of course, it'll be kind of brief, so I encourage you to speak with your social worker, wherever you are in the process, to get more information. In the second part, I'll speak a little bit about mental health, very brief kind of topics and coping strategies. And if you don't get too tired of my voice by the end of this, there is a much more detailed presentation on mental health, and you can find that on the Living Donor webpage, on their YouTube channel, and on their podcast. So one of the main roles of social work in the outpatient transplant program is we complete assessments. Whenever a patient meets with me, I do my best to hopefully make it a personable experience. I think anyone who's spoken with a social worker, really any healthcare provider, it can be quite an intimidating process. You're asked to share so much of your personal life, about your home life, about your finances, about your drug coverage, and of course, there's reasons we all ask these questions, and there's a reason social work asks that so we can better support you. But whenever I meet with patients, I try to, share pieces of myself, that I have a dog and things I like to do. And throughout the entire assessment process, I try to be as transparent with patients. I think it's really important when speaking with patients and families to give the true answers and not kind of giving answers that people want to hear. So as I kind of go through and talk about some of the financial and drug coverage resources, you'll see there are lots of challenges and barriers. And I think it's very important to validate and recognize that it is a challenge when we are asking patients and their families to come out to Toronto to get something that's medically required. One of the pieces that I do talk about, when I do my social work assessments, is I talk about power of attorney and the substitute decision maker hierarchy. The link for this will be in my email, in the resource handout that we provide. I ask all patients and even families, even my friends, everyone should kind of have one of these in place. So in Ontario, there's two types of power of attorney. It's also called a living will. There's one for treatment and there's one for finances. What's interesting is if you don't have a power of attorney, we follow a substitute decision maker hierarchy, which is what we have here on the screen. But in Ontario, there's no decision maker hierarchy for finances. So you have to kind of complete a power of attorney for finances to ensure that if you were ever unable to act on like paying bills or someone helping you with your social assistance programs or other work applications, that you have that document in place. It's also important to know power of attorney only comes into effect if you're not able to make a decision for yourself. So we always encourage family and friends to participate in all of the medical treatment decisions, but someone else can only take over care and participate in alone without you in treatment decisions if you have a power of attorney in place. Okay. So some specific things for our liver and kidney patients. For kidney recipients, the assessments are done by the social worker out in Thunder Bay. And on my next slide, when I speak about liver, social workers in Toronto do the assessments for both the kidney and like the recipients and the donor patients. That's the main difference. For both of the organs, there is a relocation after the transplant that has to take place, ranging anywhere from 2 to 6 weeks, depending on overall health. And that's just to be close to the hospital, being able to attend appointments and being able to be closely monitored. For both of the organs, you have to have a support person with you. We always encourage families to take turns and kind of share that role. It's also, supporting you with medication, symptom monitoring, and overall just the emotional toll of being discharged from hospital, having a new organ, and just the overall recovery. The other piece that I have on here is false calls. I always bring this up in my assessments with patients. So we hope that when everyone receives their call for transplant, that the organ is available and it's safe to receive. But there are times that patients are called, and unfortunately, for whatever reason, the organ is not suitable or safe to kind of transplant. And in those occasions, you have to return home, which is not good. But I think it's, again, going back to the transparency when I talk to patients and letting them know the full picture of what to expect, because I've definitely had patients get called and they couldn't receive the organ, and it's excitement to get called, but I think having the full picture is also really important. Okay. So these are some of the financial support resources. You may or may not be familiar. Whenever I'm working with patients, I always encourage, look to your employer first, see if there's any benefits. And these are some of the main ones: non-insured health benefits. There's some government programs. Again, being mindful that these are not a lot. And I think that's the piece I hope for better for our system, right? We have these big asks. Come to Toronto. You're not wanting to be away from your home, your community, your family, but that's where the care is. And often patients and their families are asked to do this big move with very limited resources. So I encourage, as you go through the assessment process, or if you're already on the list and not connected to any of these financial support programs, to talk to your social worker and find out if any of them are applicable to you. Some are more specific, like the Kidney Foundation of Canada. And pre-law, the last one on the list, is specifically for our donors. So there's specific funding allocated for that. Another big piece around our assessments is I talk a lot about drug coverage. The medications are ridiculously expensive, ranging up to 4,000 sometimes on the higher end. So drug coverage is one of the main things we encourage and ask all of our patients to have in place. And again, there's many different ways to access drug coverage. Is just finding out which would be the best fit for you, and recognizing that in itself is a stressful experience. But there is drug coverage. It's just kind of getting onto the right program. And again, the slides will be provided, so you'll have a list of all of these programs to read about. Okay. So kind of just transitioning away from some of these practical pieces. So whenever you go to meet with any of the healthcare professionals, a lot of the conversations are they're task-based, right? How are your symptoms? How are you feeling? Are you coming to your next appointment? It can become very medical-based. And from speaking with a lot of the patients and their families, there's a lot of key kind of stressors they tend to face when going through the transplant journey, wherever you are at, if that's on the list, if that's potentially being referred to transplant or in the evaluation stage. And there's the key kind of categories around like medical stressors. You're attending all of these appointments, you're being shuffled around between different healthcare professionals, lots of different terminologies being used. And it can be overwhelming, right? Social stressors, you're taking time. There's time you're missing with family, with friends, with work, changes in like your physical health impacting the day-to-day tasks of daily living, like being able to drive or being able to do grocery on your own or whatever those day-to-day things are. And just the overall emotional toll that has on everyone, wherever you are, even if you're a family member, you're watching your loved one, or if you are a caregiver, you might be taking on a little bit more. So I think, I want to validate that these are only five, there's lots more, but these are kind of five key stressors that a lot of people are facing. And it's important to recognize and know that you're not alone in feeling those feelings wherever you are with that. So these next two slides are going to be very high level of different kind of ways of thinking about going through the healthcare journey. Again, just two ways. There's many different ideas and different ways. This one is more about, the way we think about situations. So if you're in the hallway and you see your doctor and they don't say hi to you, or, hearing someone got called for transplant, or someone's on the list and you're still in the evaluation process, often that can cause a lot of automatic or negative thoughts, which is very normal. That the transplant journey is so unpredictable and so many unknowns. And so it's not dismissing those thoughts. Those are very real feelings and thoughts. But be more aware of them and thinking, reframing those thoughts, right? And going into my next slide, kind of thinking about our wise mind. I'm a very passionate person. So when I'm in those situations, I think with all my emotions. I'm very emotionally driven. And, it's important to pause for a moment and think about facts, asking questions, working in collaboration with the healthcare team, allowing your family to support you wherever you're at, and finding that balance with your emotions and reason to kind of have this wise mind. And in both of these, they're just concepts, and they're just ideas of different ways of thinking. I can talk forever about both of them, but just acknowledging there's lots of different thoughts and experiences you go through transplant. So the next piece is just around identity and kind of what I was speaking about, what people expect of us, and then the changes that you are experiencing, if that's work or school or home life and responsibilities. And it impacts your identity. You get kind of thought about as the patient. And that's why when I do my assessments, I try my best to pause and ask, what do you like to do when you're not at these appointments? How do you spend your time? Even if you used to play sports, can you still watch sports? Can you still listen to it on the radio? And finding different ways to know that your identity is not just the transplant patient. You're still a mom and a dad and a friend and a coworker and all these other things. But this is definitely something that a lot of patients kind of think about as they go through the process. And then shame and guilt. This is a tough one. I think it's one that I find a lot of people don't speak as openly about because it's so hard to talk about and think about. But being unwell, is this fair? Having to ask for more help than usual. And for the caregivers, should I offer more help? How much is too much help? And juggling all of this with the medical appointments and the medications and the symptoms of not feeling well. So coping strategies, this is again, a list of some typical coping strategies. They will work sometimes, they will not work sometimes. I think, again, it's okay to feel stressed out, and it's okay to feel sad and worried and mad and feel all of those feelings because they're valid and it's real, and transplant is an unpredictable time. It's a big process. It's a bumpy road with your healthcare team and within the system, and getting the care, receiving the care, and still living your day-to-day life. So I think if I can take away one of these coping strategies, it would probably be the daily gratitude. It's one that you can start now. And it's the small things. I often hear from a lot of patients, well, I won't be going on that trip. I can't go fishing, or the bigger things. But if we can try to focus on even 5 small things, like I listened to my favorite song in the car on the way here, or I had a good lunch. And if you actually write them down and at the end of the day review those 5 things, you'll notice it's a small thing, but it has a little bit of an impact on helping us. And we kind of heard about this from our other presenters, but communicating with your healthcare team, you are your own advocate. I like that care slide that we had around, speaking to the doctors and different healthcare professionals. Ask your questions; they are important. Go into all of your appointments as prepared as possible, and follow up. If you forget to ask someone, reach out to your social worker and say, "I ran out of time. I still have these questions." And not only focusing on the physical health, but mental health and our sleep and our mood. These are all important and all a part of your care. And these are some resources that I'll include in the printouts. Different ways to, if you're interested in some of the mental health resources I did speak about, you can find them on here. And that's it. Any questions? Yeah.
The seniors' health coverage, does it necessarily cover all the expenses of the transplant drugs or anti-rejection drugs?
We do, and for kidney, there's a specific code for particular medications. We get our doctors to write on it. So if you notice, if anyone who are taking the kidney medications specifically, there's a code for after 65 we have to get written. And if you look on the Ontario Drug Benefits website, you can search the medication name yourself, and it'll show that it's covered.
Okay, my name is Morris Wapos again. I just wanted to just ask you about your chart there regarding the financial support. Okay.
Yeah.
I'm a Indigenous person, and I believe that Indigenous Service Canada pays for, my expenses if I go, for a transplant and all that. People should notice because I have a treaty right. That's where that falls under. And it's not because of many people think that, because it's paid for like that, like I'm a, free loping kind of thing, but it's not that. I have a right as an Indigenous person, other than the, this, that other stuff that you mentioned there about, status cards kind of thing. So that has to be explained in that sense, eh? The other thing that I want to mention is that these financial organizations are identified for certain reasons. Like, they provide certain stuff. As I mentioned earlier, when you are a low income individual, you can't survive if you're on dialysis, if you have a kidney problem. Everybody knows that certain food that you have to eat is expensive. Why can't that be addressed? Instead of bragging about, Ontario Works providing this, another Ontario Disability program providing this. They only provide certain things, not necessarily to help your, your food. your meal, you know? So, I mean, that has to be, you know, addressed. Somewhere down the line, somewhere, you know, somebody has to be able to, it may not be in this form, but people should know. You know, everybody should know that it's important. Maybe this is why I see people pass on early. Like I said earlier, you know, when you're diabetic, people don't read right, and they deteriorate their body, their systems, you know, and they're gone. They have no control over that because they can't afford to have, you know, purchase a carrot that you need to eat, you know. But instead, if if uh, if somebody is providing food and they give you tomatoes, you got no choice but to eat tomatoes because you can't afford to buy anything else. You know, this is the thing that my concern. I know that there's a lot of individuals that are low income, and that's what needs to be addressed. You know, sometimes these presentations, you know, they look really awesome. They really look good. But aren't we forget the realities? You know? And I experienced that, and I see this where I am today. And I have to change my life too, you know, as a result of what I'm going through right now. So I think with that, you know, it has to be somewhere mentioned so that people can understand, you know. I hear a lot of people sometimes say that Indigenous don't pay tax. Same thing, you know. I pay tax just like anybody else. The only thing that I don't pay is that, you know, employment tax. You know, that's because I'm a treaty person. That's the only reason why. Before I get out of hand, I better quit saying these things here. Okay. Okay. Thank you.
I don't know, Sasha, if you want.
Yeah, I was gonna say I feel like I could talk to Morris for a long time. You're very insightful with all of your thoughts, and I agree. You're right. There's lots of myths around NIHB and people thinking that's being the non-insured health benefits program and people having assumptions that's being misused. I think that's a really good point. And I agree with what you said about the financial resources not being enough and not addressing what people's actual needs are. And I think that's the hardest part about all of my assessments, that I meet people who are struggling in so many different ways, coming from so many different places and communities, and it's so limited. And when I think back, to my patients who have helped from Thunder Bay coming out to Toronto, I write so many emails, so many letters, and it's all this runaround, and I can't even imagine what it must be like for the patient and their family who are doing that. Like, I'm writing this one letter, but it's the family who's facing the direct impact of food insecurity, of not having the money to pay for the food they are required to eat, living off of what I don't even know how Ontario Works comes up with their numbers, right? Like it's not reflective. And then I agree. I wish I could make those changes. Um, And I think it's important to hear one of my lifelong goals for UHN is to have a liver or kidney support group, because I think more than what I have to say, I think it's more important to hear from what patients and their families have to say, and talking to each other and sharing your own experience of how challenging it is. Because I think there's so much to learn just by hearing you, ask questions to myself and the other presenters. You have so much insight and so much knowledge, and I think that's what's a big, we can't change the system, but we can start small, and having a support group where patients, people like you can share their thoughts and insights and provide education informally is really important. Anyone else?
Next up, we have Candice.
Okay. We are talking about a lot of heavy stuff today. And I used to do improv all the time. So we're just going to do something really quick to kind of, brush a little bit off so that we can continue with, unfortunately, some more heavy stuff. So if you're able, if you can stand up, we're just going to do 2 really quick things to kind of adjust our feel in the room, and then we'll sit back down. So the first thing, you're going to feel really silly. We're going to take our fingers up to the sky, and we're just going to go below. Take it all out. Do that one time. There you go. And then we're going to reach our hands up to the sky, and we're just going to pull all of the good energy from the room and all the good thoughts that we have about the Jays, and we're going to pull it into ourselves and hold it there. Okay. And then we're going to take really deep breaths with all of that lovely stuff. And then we're going to sit. Okay. All right. Now that we've shaken off a little bit, let's give this a try. So my name's Candice. I'm with the Center for Living Organ Donation, and I'm also a kidney transplant recipient myself. So I've really connected with hearing from other patients today. I was also a crash start onto dialysis, did hemodialysis, then peritoneal dialysis at night when I was 24. And then I received a kidney transplant 16 years ago now in September. So I've been through this personally, and now I work in this field. So I work with the Center for Living Organ Donation. We were created in 2018 by UHN Transplant, and our goal is very specific to improve access to living organ donation for people who need a liver or kidney transplant and those who want to give that gift of life. Now, we have lots of services available. We have an info line and an email you can call or send us an email anytime. We do lots of webinars. We find since COVID, it's actually been a big benefit to go online because more people can access our information. We have a volunteer program. We do public awareness every year, Living Donation Week, and we have a campaign, Great Actions Leave a Mark, I'll show you more about. Okay, so you don't have to say this out loud, but I just want you to kind of think about where are you in your kidney or liver journey? Are you exploring feelings about organ donation, learning about organ donation? Have you ever thought about finding a living donor or helping a loved one find a living donor? Have you started working on a campaign, maybe for yourself or for a loved one? Or maybe you already have a living donor in workup or are a potential donor yourself. So kind of think about where you are in this journey. You're going to hear a lot today about organ donation on both sides. They're going to go into much more depth than I'm going to talk about today, but I like to kind of give a little bit of an overview on some of the benefits of organ donation living. The biggest one is it allows for a shorter wait for transplant. We've heard from people today who waited on dialysis 4, 6, 12 years. Whereas with our living donors, most people can have that transplant within about a year. It's a planned surgery, so we know it's going to happen. We can do things like let our work know, have somebody take care of our pets. One thing I did was make a bunch of food and put it into little individual meals and froze it. So when I got home, I didn't have to worry about cooking and all of the disaster that, that comes in your kitchen.
And then it's generally faster recovery and better outcomes with a living donation for patients. It also reduces the risk of getting sicker while waiting or dying on the transplant list or missing an opportunity for that transplant, that call that comes in. Maybe you're far away and you're not able to get to Toronto in time. Maybe you're not able to hop on a flight in 30 minutes. So living organ donation provides the ability to reduce these barriers. So who is eligible to be an organ donor? This kind of helps us in knowing what we're going to talk about when we're going to write our appeal or talk to people about living donation. And I normally do this presentation in a full hour, so I'm going to talk really quickly, but you're going to get my full hour presentation in the slide deck. So for kidney donors, they need to be at least 18 years old. For liver donors, 16 to 60, and no major health issues, no diabetes, heart disease, active cancers, be a healthy weight for their height, and a compatible blood type for liver donors, but there are options available for kidney donors. And you can see in the chart here, you can look at where your blood type is and scroll over and see who you can normally receive an organ from or who you can donate to. So using me as an example, if we look at B, you can scroll over and see I can receive an organ from B positive, B negative, O positive, and O negative donors. So really anybody who is deemed eligible on that previous slide is able to be a living organ donor. Some people think it has to be a relative, but most organ donors in Canada are actually not biologically related to the recipient. You're most likely to find a living donor within your extended network, and those public appeals can help, and we'll talk about that. Criteria for organ donors is different than it is for blood donors. So somebody who might not be eligible to donate blood may still be able to be an organ donor, and that was the case with mine. And the donor also does not need to be the same ethnicity. That matters for stem cells, but it does not matter for organs. And my favorite part of my job is talking to living organ donors about why they did it. Some people have a connection to transplant. Some people have a connection to the recipient. But other people just want to do something really meaningful. They appreciate their own good health, and they say to me, what's a better gift to give than the gift of life? And all three of the people on this slide here are anonymous, non-directed donors. So they donated to somebody that they have never met and will never meet. Okay, so the big question that I'm asked several times a day is, how do you find a living donor? Today, I'm not going to teach you how to ask somebody to be your donor. That's impossible. I went through this as well, and it's hard enough to ask somebody to watch your dog or to pick you up from the airport. So to ask somebody to donate an organ feels quite the feat. We're going to teach you how to best share your story so that people can learn about your journey, they can get the proper facts, and really understand that pathway to transplant. So we're not asking for a donor, but we do have an ask. The ask that we're going to put out into the community is to share. Will you share my journey? Will you help me in, sharing this story through email or at your work or maybe posters, and we'll talk about different options there. And then identify a loved one to help spread the word on your behalf. And we call these people champions, and I know there are some champions in the room today. So thank you so much for being here. And then we'll consider traditional media and social media. So who are these living donor champions? Really, they are anyone who is willing to support you and spread the word. Starting this conversation, it says on this slide, is hard. It feels impossible. And these people can be emotional support for us. They can talk about living organ donation. They can, really take that pressure off of us to try to stay healthy while we're waiting for our transplant, and they can do that hard work of sharing our story. They can be anyone who is comfortable sharing your journey. They might be good writers or people who feel comfortable on social media, maybe people with connections in the community. So there's lots of ways to get your story out. Conversations is the most obvious, but when I talk to people about that, they say, I'll never talk to anybody face to face about this. This is a really scary thing to sit down and have coffee with somebody over. So a lot of the people who I talk to go to email, blogs and newsletters, and social media, because you can really craft your story and edit it a few times and then put it out once you feel comfortable with that. Also, traditional media is a good place to go, as well as interest in hobby or faith groups. And then everybody asks me about billboards, bumper stickers, and t-shirts because we see it on the news. The problem with them is that they're really expensive and it's not a large reach into the community, right? You have to see the t-shirt, you have to be able to read the tiny bumper sticker, and a billboard, you have to actually drive by and be able to write something down as you're driving by the billboard. So what we want is high reach, so a really large amount of people to see it and the ability to share it within their networks with low cost or no cost. So that's where we see those email, the social media, and the traditional media. Okay, so I'm going to talk a little bit about a template that I'm going to send to you all as well in the email that I'm going to send out. But we want to collect a bit of information before we sit down to write our story. We want to make sure that our recipient is on the transplant list or eligible to be on the transplant list, and that they're eligible for a living donor. So not everybody is eligible for living donation. We want to ask our transplant team what our blood type is, so we know the blood types that our living donor can be. And for kidney donors, we're going to provide information about Canadian Blood Services kidney pair donation program, which is basically a kidney swap. So you go into the program with non-compatible donors, and those non-compatible donors can donate to a stranger anywhere in Canada, and another non-compatible donor can donate back, and we really swap kidneys. I know it's kind of a silly way about talking about a beautiful, large national program that we have, but really kidneys are swapped across Canada from BC to Atlantic Canada. And when you don't have an eligible donor who's compatible with you, but you have a donor who's eligible to donate to somebody else, this is a really good way of opening up the field to find a donor for you. We want to know who the living donor should contact with questions. If you're at UHN, it's the Center for Living Organ Donation they can ask, and how to apply. And again, at UHN, we have a health history form that can be sent out to the potential donor. They fill that out and send it back to the living donor offices. So next, we are going to do, in my opinion, the most important piece of the template, and that's talking about yourself, which is often sometimes the hardest piece to do as well. So we want to know a little bit about you. Who is the person who needs the transplant? What are some of your hobbies? Do you have a workplace you want to talk about, or maybe you're retired? Who do you enjoy spending time with? Talking about your family and your community that you're part of. How has your life changed since your health started to decline? I used to have much, much longer hair than this, and I cut it very short when I was on dialysis because just the act of washing a lot of hair would take so much energy out of me that I was like, I'm done with that. It's braids and shorter hair. And for a lot of people who didn't know what it's like to be on dialysis, that was a shock to them, that even trying to wash my hair made me exhausted. What's something you're looking forward to doing after transplant? For me, one of the big things was food. Anybody who's on a renal diet in here understands that. I really wanted a bowl of chili. And then I had big dreams as well, right? I wanted to finish my degree. I wanted to travel without worrying about dialysis. These things that we think about when we're on dialysis sometimes as things that we don't know are possible. And we want to share that about ourselves because it is possible. Okay, and I realize I didn't skip this slide. So this is a story example that was provided to us. I'm not going to have you read it all, but Vanessa's sharing her story about being a daughter, sister, aunt, a rescue dog owner. She worked in childcare for a long time. She enjoys camping with her rescue dog, but since her health started to decline, it's harder and harder, of course, for her to do dialysis while camping or having that energy to do these things. She talks about her diagnosis and how she's now at the point where she needs a living donor. And at the end, she says, she's hopeful that she'll find a living donor and she needs someone brave and generous enough to give that gift of life. So this is a really nice story about Vanessa because the piece about wanting to know about her is in there. We can connect to Vanessa. We know about her. You know, somebody might read this and connect that they have a rescue dog as well. But let's say they wanted to be Vanessa's donor. They don't know how. They don't know what her blood type is or where she's located. They also don't know how to ask questions about the living donation process. So that's what we're going to do next. We're going to complete this template that I keep talking about that I will send you. And we're going to get the crucial information that is needed for donor applicants. So the city that the person lives in, their blood types, and I know I keep harping on that, but we're going to include positives and negatives. Often what happens is somebody will say, I need a donor with blood type O and B. And then somebody will say, well, I'm O negative. Can I donate to somebody who's B positive? So we're going to list all of those blood types: O positive, O negative, B positive, B negative. We can include information about the kidney paired donation, the exchange, the age range for donors, and all of this is in the template. So you don't have to remember any of this information. It is provided in there. We can include things like surgery details, how much time the person might need off, the website where they can ask more information, and of course the big one, how to apply. So some people might jump right in and put in an application right away. Other people might need to, simmer on it a little bit and find more information and contact the center and ask questions. We want to make sure that everybody has the information they need. And then we ask people to send questions to the center or send questions to your coordinators, but not to contact the recipient or your family. It really violates donor confidentiality, and we don't want family members or potential recipients to advise people about medical histories or whether or not they should apply. So here's another story of Vanessa. She says right up front, she lives in Mississauga. She needs a living kidney donor with any blood type to donate to her in Toronto. Then she goes on and talks a little bit about the donor process. She says that, the survival rate for kidney donors at Toronto General is 100%. They don't need to be blood relatives. She talks a little bit about the kidney paired donation program. And she provides information in there about how to apply. So there's a link there. She provides her birth date. And then you can see at the end, if you have any questions, reach out to the center. So this is really great because it's really informative about what people need to know when they're potentially going to be a donor. But what we're missing here is the heart of her story, right? We don't know who Vanessa is truly at her heart outside of her disease. And we know, everyone in this room knows we are much more than our disease. So what we want to do is put these two incomplete stories together. And there's an old marketing saying, and this is spelt right, called don't bury the lead. And basically what it means is state what you're looking for up front. We know now in social media, people have like a 5 to 7 second attention span. So we really need to connect with the person right away, get that information that they need to know, and then we're going to start talking about our personal journey, some information they might need to know. And at the very end, we'll provide resources because people who are really interested in becoming your donor are going to read all the way through this to the very, very end to get that information about resources. Often we do it backwards, right? We talk, I'm on dialysis. I've been on dialysis for 18 months now. This is who I am. I don't know my diagnosis. And then at the very end, I say, and I need a living kidney donor. But most people have lost, their energy or their interest by then. So we want to state right up front, Candice needs a living kidney donor with blood type O positive or O negative to donate in Toronto. Then we can move on to our storytelling. So this is an example of a person who gave us consent to use their appeal. I'm happy to say that this is a very old appeal. You can see 2020. They did find their liver donor, but this is using the template that we have. So at the very top, you can see the ask. And the ask isn't, will you be my donor? The ask is, please share. So we want to include that every time we send an email or put out a Facebook post. Then they go on to their lead. My name is Joe. I'm looking for a living liver donor with blood type O positive or negative to donate in Toronto. So if somebody reads nothing other than those 2 sentences, they can share this and, maybe people in their network will see it. Or they can move down and read a little bit more. They can read about liver donation. They can read about this person's personal story of being Guyanese, so they don't have a lot of family in Canada. They talk about how they used to love riding their bike and ice skating, but now they watch a lot of cold case files because they don't have as much energy. And they include their goal there too. Post-transplant, their ambition is to finish school and work in the justice system. And then at the very end, we have how to apply and additional resources, because again, people who are really interested are going to read all the way to the end. So now that we have written our story, we're going to decide where we're going to share. And this is completely up to you, whatever is in your comfort zone. So, and I say that with the caveat of try to push outside of your comfort zone a little bit, if that comfort zone keeps you in your inner circle. So we're going to decide if we're comfortable sharing publicly or more privately. Publicly, we would look at things like social media or traditional media, but really where we want to start is brainstorming our networks. So thinking about our extended community. Who are your neighbors, your coworkers, groups and affiliations you might be part of? Maybe it's a faith group, and consider social media. So what we really want to try to do is thinking about, often we get stuck in thinking, I have 5 people in my life, none of them offered to be my donor, or none of them are eligible, so I'm done. There's nobody else who can possibly donate to me. There's lots of people in your life who care about you and want to help you. They might just not know what you're going through. This is a slide of brainstorming that we've done with lots of people. I stole it from a multi-level marketing company because they're always trying to get people to, come to candle parties and things like that. But it's really just a list of potential people who could share your story, whether it's your hairdresser putting up a poster, your dog groomer, Chamber of Commerce, teachers, chiropractors. One that stuck out to a recent webinar that I did was a coffee shop barista. So lots of ideas of where we can share our story. If you decide to use social media or traditional media, there's some pros and cons. So it's a really effective way to share our appeal quickly with a large group of people in your network and beyond. It's little to no financial cost, and that appeal can be reshared and gain traction on its own. The cons are we're disclosing our personal health information online, right? So that can be scary for some people. It might involve details of your family or other sensitive information. And although it's our information to share, once it's out there, we don't know how it's going to be used or how it will be shared. These are a few social media examples that worked. They gave us consent to share these. As you can see in each one, the first thing that's said is please share. And then they go on to the information. You can also see that Facebook cuts off text. And I don't know about you, but I often don't click show more on Facebook. The other thing that's really great is all of these have really beautiful pictures and text within the picture. So if people decided not to read the text at the top, they could still see the most important information on there. And I just want to point out Pam on the far left. She was a nurse who had an accidental needle stick that caused her to contract hepatitis C and need a liver transplant. And you can see her wonderful family in here. None of them were compatible with her. So she went online to her nursing community trying to find a living donor, and she thought, yeah, it'll probably be a nurse who donates to me. The person who donated was 3 circles out of Pam's normal circle. So it had been shared on Facebook that far out, and he was a young gentleman. And when asked why he became her donor, he said, she reminded me of my mom. And if my mom didn't have a donor, I would hope that somebody else would step forward on my behalf. So you never know where your donor is going to come from or who it's going to be, but we can't find a donor if you don't put your story out there. If you decide to look to traditional media like newspaper, radio, television, they're often looking for stories. So share your story with them. Sometimes they might see your appeal on Facebook, but more often than not, you should reach out to them because they're always looking for stories and they kind of get a 2-for-1. You get to share the story now looking for a donor, and then share the story later when you find the donor. And it's free and has a massive reach. Okay, so I promise here I'm almost done. I always want to talk about when you choose to share, remember consent. So be considerate of anybody who's involved in your story, pictures or recordings. And if you get a donation from an anonymous living donor or a deceased donor, please refrain from sharing the exact date or time of your surgery to respect the privacy of those people involved. This, I have about 15 slides on Facebook appeals and how you can boost posts on social media. And I will send the full deck to you guys so you can take a look at that. But one thing that I want to point out, if you're using Facebook, to use a new page, because when we use our profile, it's private and you have to be a friend of that person to see it. Whereas if you create a new page, anyone can follow that page and anyone can share that information. So once you decide to, launch your campaign, stay positive, keep sharing. Remember that not everyone can be our living donor, but everyone can share your story and champion your cause. Some things to keep in mind: potential donors can ask questions by reaching out to us. We ask that you don't give medical advice about the donor criteria and the screening process. And the transplant team will discuss all the risks in the assessment with those potential donors. The other thing is we can't share who or how many donors have stepped forward for you. But if you've put out a campaign and you're wondering, should I keep going on this campaign? You can reach out to us and we can say, it's a good idea to keep looking, or at this point, you no longer need to continue posting. Some final thoughts: we're telling our story. We're not asking for a donor. We're sharing and asking people to share that story. Champions can help spread our story. Make sure you get the facts from your transplant team. Don't bury the lead, so put a summary at the start of your story. Include complete information on all of your posts. We don't know if that person has read your first post. Unfortunately for us, the search does take time and patience, but know when we talk to living donors, they say they want to donate. A lot of them would do it again. There's a community of support ready to help here, and know that you are worthy. Some success stories of strangers becoming donors and recipients just by those recipients sharing their story. My favorite, a hot dog stand owner and his customer went from strangers to donor and recipient. Every Tuesday and some Wednesdays at noon, we have free information sessions. So if you have a donor who's interested in learning more, you can always send them our way. Everything's on givelifeuhn out of eventbrite.ca of how you registered today. This is our national campaign, Great Actions Leave a Mark. Lots of stories on there that you can go look at from all across Canada about living donors and recipients of living donors. We have a YouTube channel. If you prefer to watch videos, then read manuals. You can check us out at givelifeuhn. We have an African, Caribbean, and Black organ health YouTube channel, and Kamika is actually one of the videos on there, so you can go and listen to her story as well at acborganhealth.ca. And for more information, you can always reach out to us. Thank you so much. I know this is a difficult topic to talk about, but we're always available to discuss anything you need.
I have a question.
Yeah.
Well, not really a question, but maybe something that might be missing from your presentation is who not to get a donation from. Because while I was on dialysis, I gotten so many messages either on Facebook or email. I'm not even sure how they got my email, but from people from out of country saying if I give them $10,000,
Yes.
that they would give me their kidney, or if I could pay for their plane ticket over,
Yes.
that they would go through the surgery. Like, they target vulnerable people.
Yes.
And it's something to watch out for. So, I have, unfortunately, a lot of friends that are on dialysis now. And I always caution, stay away from those. I wish I
Yes.
had saved them, but it was from an email when I was much younger. And I don't think that email was I can't remember what that email address is about, but.
Yeah. Actually, we get a lot of those at the center as well. So emails directly to the center saying, if I donate, anonymously, will you pay for that organ? So you're right, adding that in of, things to be wary of, specifically on social media as well, because there are people who will reach out with those questions too. Yeah.
My question is, how many people can be tested at one time? Like if you have somebody that's come forward, should you wait until their testing is done before you reach out to other people?
Do you want to answer that, or do you want me to? So what we always advise is if there's multiple donors, for all of those donors to submit their health history forms, so their applications. And then what will happen is that living donor team will look through all of those applications and decide who they think is the best possible donor to start with. And they'll work up one donor at a time. But we always recommend, if you're doing something like an appeal, to let people know to, yes, submit your health history form, and then the team can kind of go through those applications and decide who would maybe be the best fit. Did I miss anything? Okay. Yeah. Sorry, why we look at one living donor per recipient?
Sorry, just one recipient at a time. I think you said you'll kind of look at the paperwork for everyone, but then people are processed like one at a time.
Yeah, so it comes down to resources of processing one living donor at a time. There's lots of people in the system right now, and so I'm pretty sure it's all of Ontario that just does one at a time, isn't it, Cynthia?
Yeah, that's
Yeah.
correct. It's because usually it takes about 3 months to work. I mean, I work on liver, so I don't know about kidney, but for liver, it takes about 3 months to work someone up for live donation. So if you're working up multiple people at a time, it's gonna be really hard for the system to keep that, benchmark evaluation time.
Mhm. And that's why we recommend, if it's possible, to submit those health history forms at a similar time for any potential donor, and then they can kind of choose the person that they think would be best to move forward with first. Yeah. And I will provide you guys with the extended deck so that it's all in there. And I do this a lot, the Finding a Living Donor sessions. So I always would love feedback from people who read that. If you let me know things that you think should be added or maybe removed as well, that would be amazing. Another question? Yeah.
Okay, it's me again. I just wanted to talk about the success story that you talked about there. I'm not at that point yet in my kidney disease here. Um, I'm just sitting there listening to you talk about that success story, and it sort of makes me depressed just on my own, like as an individual, like at that, because I'm not at that point yet to have a success story. The stories that I have is my experience at this point, but it's not a success story. The only other thing that I want to comment is that the social media stuff you talked about, you can put it on Facebook if you want to start a rumor. That's all it is, and because I do pop into that system every once in a while, and the comments that I see there is not not great. I guess it's something that people just say what they want to say, like you start a rumor. But I guess, like, if you read this, same thing, like, I mean, I don't know how it would fare if you put it on Facebook. Like, I mean, I'm sure some people would um, would learn from that, and some don't. You know,
Mhm.
I always view that Facebook has three different kinds of people. You know, and so everybody's mind is different.
Mhm. Mhm.
So, I mean, that's all I wanted to just mention on that, um, and I'm just keeping my fingers crossed that I have a success story at some point somewhere in the future.
So I want to start by saying I disagree with you
you.
when you say that you are a success story. You're here and you're learning and you're resilient by going to dialysis and continuing to do that treatment. It's not an easy thing to do. I know it's been a long time since I've been on that machine, but I can still feel what it felt like even all of these years ago. So I think definitely rephrase yourself in knowing that you are a success story, in continuing to be resilient. But yes, in a different sense, transplant as another mode of treatment, right? Transplant's not a cure, it's just another mode of treatment. And there are different options for different people, right? So I only have a short amount of time here, but I would be happy to hop on a call and we could chat about, some ways that maybe we could connect with your community, or, places that we think we could share your journeys in ways that might be connecting to the community. Yeah.
I guess I'll say anonymous donors actually meet their recipients, because I know of somebody who just, I don't know them personally, but I know of somebody who just had a transplant last week, and they had a donor who, they didn't know, but they connected and, are now friends. But I just wondered, how typical is that?
So we don't have stats on that because in Ontario, we protect the identity of non-directed or like anonymous donors, similar to how we protect the identity of deceased donors and donor families. But what can happen is you can send letters through the transplant program. So the recipient can send a letter to the transplant program, and then they can ask the donor if they would like that letter. They say yes, they'll pass it along, and then the donor can do the same thing. So they could send a letter back and forth. We highly recommend that, like what I said, people don't share their dates and times, because what's happened is people can go online and post their date and time, and then somehow through some network they can connect that way. And we want to be cautious, not every recipient wants to know their donor. Not every donor wants to know their recipient. We have a very active volunteer who's an anonymous donor, and she said, in my opinion, in my brain, my liver is living on in a child, and that child's still healthy and that liver is still functioning. And she said, I don't want to face the reality that that might not be happening. So for me, I'd rather not connect with my recipient by sharing letters. So it really protects both sides by not connecting them. But of course, they can send letters. And if both sides accept, they can exchange letters that way. Mm-hmm. Yeah, exactly. So a directed donation would be somebody who knows you, who decides to donate directly to you. An anonymous donor could be a directed donor, like maybe they see the story online, but they don't know the person and they decide to donate to them. Or it could be anonymous, non-directed. So somebody steps forward and says, I'd like to donate a kidney or a portion of my liver to whoever needs it. And our numbers are growing. I think on the liver side, I think we're at like 140 or 150 anonymous liver donors in the program, which is kind of amazing. Yeah.
All right, we have one more speaker, last but not least, and then we're going to take a short break. I'm so sorry, Crystal. I'm not really introducing all of the speakers, so I'll just ask you to introduce yourself if you don't mind. Thank you.
Anin Buju, Sagwana Kwan Dishnakaz, Makwan Dodem, Binjavik Zaging and Ishnavek and Donji. So my name is Crystal Hardy, and I'm from Rocky Bay First Nation. And I want to start out by telling Mr. Wapoose that I hear you. Also, as I share my story, even writing out what I was going to say today, I was really emotional as I'm going through, living through my transplant journey too, hopefully. So you're gonna have to excuse me if I'm emotional throughout this. It's a deeply personal journey. And so for me, it started in 2018. I was working up north in Flying First Nations. I had graduated from my undergrad. I was excited to be working in community, supporting health initiatives, supporting youth, doing a lot of the work that really spoke to my heart. And then I started to get sick, and I didn't think much of it. So for me, I was symptomatic, unlike the previous speaker, who had no symptoms. I did start to have symptoms. It was quite a bit of nausea. She just stole my napkin. So, it's pretty severe nausea. I'd go to Tim Hortons, grab a tea, go off to work with my brother. We worked together at the time. And halfway through, we'd be driving around town with the boys we worked with. Thank you so much. And I would be nauseated. I'd have to pull the car over and get out and be sick. And this went on for months, on and off intermittently. And so I thought, oh, I must have a bug, or maybe the cream is bad in my tea. Like, I couldn't figure it out. But it progressed steadily, incrementally. And then eventually the nausea and the vomiting became so bad that I couldn't ignore it anymore. And I had to go to the emergency room. And so my younger brother brought me to the emergency room. And because my parents were overseas and weren't able to get back home. So he brought me to the emergency room. And I sat in there waiting for quite a few hours because although I was symptomatic, I was nauseated, which wasn't really a significant indicator, to be triaged immediately. And so I waited for hours in the emerge. As many of you know, the emerge at the regional can be quite inundated. And so I sat there for a while. I finally got into a room. The nurses did they did some blood work, and it came back, and the doctor came and told me that the reason I was so sick is because my kidneys had failed and my body was shutting down. And so I sat there and I was afraid because, like, in that moment, all of the dreams, the hopes, the aspirations I had for myself, I felt like they were ripped away from me. I didn't know what it meant. I thought it was the end of the line for me. And I was trying to reconcile that in that moment, alone in the hospital room. And then my aunt, who I didn't know was going to be here today, so happy to see. My aunt came and she sat with me in the emergency room for, I don't know if it was a week. I don't know how long it was because I was in and out of consciousness. And I remember I wasn't too cognizant, but I do remember hearing whispers of people wondering if I was going to make it, people coming in and out. And so I was afraid. And then somehow I stabilized well enough to start hemodialysis. So it was a life-saving treatment for me. And I started to feel a little bit better. I was scared to go on dialysis because all I knew about dialysis was what I'd heard from people on my res. Stories about people on my res, and often it was just that they lived 1 or 2 years on dialysis and then passed away. And so that was tough. I was like, is this going to be what my life comes to as well? I know I have so much I still want to do and so much to live and see and so live for and see. And, I had my nieces who had just been born. And so I was trying to wrap my head around all that in those moments. But I went into the dialysis unit here at the Thunder Bay Regional Health Sciences Center where Dr. Mucsi and I went this morning. And it was really a very welcoming place for me. And I know that's not the case for everyone. I want to honor what Mr. Wapus said. I know it's not the case for everyone. But in that moment, it was very welcoming. The nurses were friendly. They supported me. And so for me, I started to go in and it felt like it was maybe something like a community, where I was greeted and eventually my aunt introduced me to her cousin, Mona Hardy, who was also on dialysis. And Mona was like this gregarious, vivacious, vibrant, loud woman. And she made everyone laugh in the dialysis unit. And I was like, I heard that, she told me a little bit about her story, what she had done in her life through the years that she'd been on dialysis. And I started to have hope that maybe I could begin to build a life around this, this treatment and this intervention. And so I continued to go. And there were challenges, there were times when my potassium was so high, it was at critical levels and there was nothing that we were doing that could bring it down. And there was sort of the fear attached to that, the precarious nature of trying to balance, all my electrolytes and learning how to moderate my food so that I knew to limit my phosphate, my potassium, my sodium. And I think, again, Mr. Wapus mentioned some of those things. And when he talks, it really speaks to my heart because I know I went through the same things. And so trying to learn what foods are okay can be a big, scary world. And I think how I navigated that was because I wasn't able to travel in the north anymore and kind of do that work that really spoke to my heart. I decided to go back to school and do my master's in health sciences with a specialization in Indigenous and Northern health. And I thought in that way I could expand upon my capacity and build up my skill set in the times when I couldn't travel, and in a way continue to better myself and further that sort of whatever it was my spirit was calling me to do. And I do want to just briefly mention, Mr. Wapus, that I did during my master's publish a work on the critical nature of food in First Nations communities and access to food and underserved populations and some of the socioeconomic disparities that impact access to food. And so I don't know if we can talk later, but I think building out that work is really important. Like I agree wholeheartedly, and it's a critical component of health outcomes. And so I did that. Worked on my master's, and I think having that sense of purpose while I was on dialysis, and I'd even talked to nurses about weight training and stuff. Weightlifting and working out at the gym was another huge passion in my life at the time, and that gave me something to live for. And having something to live for really, I think that got me through the tougher moments on dialysis, on hemodialysis the first time around. And I think that's really important, is to have purpose in life when we're going through this, and to have something to look forward to, and to not leave our spirit untapped in that way. At least that worked for me. And so eventually I was working on probably my literature review for my master's thesis, and I got the call. And so, like the other woman was talking about, that's like a powerful moment. I was sitting on my couch working on my literature review, and then I got the call, and he wasn't as new, but he was like, it was November 4th, 2021 when I got the call. And he said, yeah, you're up on the list to like get your stuff ready. It's time to fly out. And another deeply deeply emotional moment. Like I had transitioned from hemodialysis to peritoneal dialysis, which is when, like she said, you can hook up to the machine at night and get yourself balanced at night while you sleep. It's a longer treatment and it's more consistent. You get to do it every night. I think it's a little bit easier on the system. So it works really well. And at the time I was doing peritoneal dialysis, and my niece, who had grown up kind of with that for the 3 years, she would put on her mask at night when it was time for me to connect, and she would sleep over and she'd put on her mask and she'd sanitize her tiny little hands, and she would sit on the bed knowing not to touch any of the implements because she knew it was, a critical procedure that had to be sterile. And then we'd go to sleep and the machine would alarm at night, and she never said a word. It was so I got that call and I went, I thought of her, and having sleepovers with her and how patient she'd been and how loving she'd been as just a small girl. And she didn't complain about it till after my transplant. And she was like, I hated that machine. And we laughed. So anyway, I got my transplant call. I think I got the call on November 4th, 2021. And I was just kind of, I was in awe. I was just flooded with emotion. I was like, wow, I get to be alive again. I get to be alive. I get to travel. I get to go see and do all the things I want to do. I get to finish my degree. I get to go live life and do research. And so me and my mom flew to Toronto. We left within that hour. My mom came with me. And here's another thing is I was fortunate to have a mother and a friend who could come with me, who could escort me to Toronto and stay with me. And a lot of people don't have that, particularly from First Nations. There's no funding for that built into the system. And so it's something we need to address. But my mom and I flew. And then November 6th, 2021, I got my transplant. And so I got a kidney pancreas transplant because I'd had type 1 diabetes from the time I was 3 years old. So it was a progressive illness for me. And so all of a sudden I had a new kidney, and I also I could eat sugar. I didn't have to take insulin, like injections anymore. It was like a whole new world. And that was incredible. And some of my beautiful friends are here today too. And some of them might remember that I decided we would meet regularly. We went to grad school together, and we would meet regularly to try to stay sane in the midst of all that. And I told them, like, yeah, this is my year. I'm going to say yes to everything. And they encouraged that. And they were like, yeah, you got to go travel and do all the things. And so I did that. And so for a couple of years, I traveled coast to coast in Canada, presenting my research, some of the research, about food security in First Nations and the impact on chronic kidney disease. And then some other stuff I had done as well. And so I traveled to every major city in Canada, and then I got the opportunity to go present some of my research in Australia last November and December at a couple of different venues in Australia. And so I went ahead and I did that. And it was a beautiful experience. I was gone for maybe, I don't remember anymore, maybe 4 weeks. And I came back after Christmas to Thunder Bay from Perth, and it was quite an adjustment. And I got pretty sick. Like I was kind of in a feverish state for a couple days. And I didn't think much of it. I was a little bit in the back of my mind, maybe I was wondering if I should get checked and if I should do something, because I was a little bit concerned about an AKI. Because one thing I should mention too is that after my transplant, everything wasn't good. It took me a full year to recover because of the complications and infections and additional procedures I had to have done. And I think my EGFR, or like my baseline kidney function, only ever went up to about 25%. And so it wasn't fully functioning, but it was good enough to give me the life I was happily leading, right? And so in January, I had a follow-up with my nephrologist, my transplant nephrologist in Toronto, and found out that some of my blood work came back abnormal. And so my creatinine had jumped, which is kind of an indication of how well your kidney is functioning. And it was quite high. And so there were some other levels that were irregular and abnormal that my nephrologist thought maybe I should get a biopsy on the kidney and check the state of it. So by March, we had the biopsy done, I got the results back, and it turned out that the transplanted kidney had atrophied significantly. And so it was shocking, but I was still hopeful. I thought maybe like there was a way to regenerate it. I wasn't quite familiar with all of that yet. But I started to get sicker and sicker, and it was like the nausea that I had experienced initially started to come back. I started to get sick. And at the time, I should mention, in January, I started doing my internship with Dr. Mucsi at Toronto General. And we were co-developing the Indigenous Kidney Health Project to look at addressing barriers across the continuum of care, continuum of renal care for Indigenous First Nations renal patients. And so we were in the process of developing kind of the pieces to put that together when I became sick. And I think around March, took a look at my EGFR when it came back from UHN and the results, and I saw that my EGFR was 14, which is basically an indicator that my kidney was functioning at about 14%. So I called Dr. Mucsi, or texted him rather, and I told him what was going on, and I said I might have to step back a little bit while I take care of my health. I don't know what's going on or what kind of the outcome is going to be or how this is going to unfold in the next little bit. And he was so incredibly supportive. He, I was in Toronto at the time, newly transitioned to Toronto. All of my friends are here. My family was here. And I was kind of trying to reconcile that, going through that again. And so understanding more now than I did last time about kidney health and kidney function and what sort of the abnormal levels meant, I think was really tough. So I talked to Dr. Mucsi, and I was like, hey, my EGFR is 14. I haven't been started on dialysis yet. I know like preventative dialysis is more effective in the long term. And so he was able to support me in getting started on that. And I think that was like a really important step in kind of helping me start to pull myself back together again and get back to hope. And so I started dialysis in March in Toronto this time, which has been, it's not an easy process, like you've heard from a number of other people who have gone through it. But I think recently with the support of people like Dr. Mucsi and my friends and my supervisors, people I'm close with. It's been possible for me to keep going with the work we've been doing. And so, we slowly, very slowly continued to put the pieces of the Indigenous Kidney Health Project together throughout this when I was able to work, and kept pushing through. And I went through my transplant workup. Dr. Mucsi took time out of his, busy life. Anyone who knows him knows how busy he is. And he came and talked to me about getting a live donor, which was something I hadn't considered. Something I didn't have a lot of information about. And just told me about the improved outcomes with a live donor and what that could mean. And then he also offered so kindly, to have anyone who is interested directed to him, and he would speak through or answer any questions and guide them through their process on their end. And so that's been invaluable. So that's where I am now. I'm back on hemodialysis at the Toronto General. I can no longer take the peritoneal dialysis because I do have a pancreatic transplant in the peritoneal cavity, and so I can't do that. And hemodialysis is not always easy. Right now, we're having difficulty removing fluid. So the last couple of weeks, I've been into dialysis 4 or 5 times a week, which is really hard. Eats up a lot of my productivity. And so I also have to apologize because I wanted to have a slideshow for you, but I don't know what I could, I just didn't really have the capacity because I was in dialysis so much and it was just leading up to this really difficult to organize. But now I'm waiting to hear what goes on with my donors. And and continuing work, the Indigenous Kidney Health Project, because I think that really, what speaks to me is Mr. Rapus he thinks all he has is lived experience, but that's the most important thing. So that's all I really had to. That's all I really have to. And those are the important pieces, I think, that help us put the puzzle back together and help us fill the gaps. That's the kind of information we need, Mr. Rapus, is that lived experience and understanding what you see and what you experience. And similarly, I'm watching what I see, what goes on in the dialysis unit, what it's like in my pathway, however slow it may be forward, and taking note of that. And I think the hope is in the long term that at a really sort of complex and complicated trajectory from diagnosis to transplantation and back again through the cycle. But the hope is that lessons can be learned, maybe from some of the things that I've gone through, some of the gaps that exist that have emerged from different sort of pieces of my story. And we can make paths forward easier, sort of like what Leona said for other First Nations patients. And so I think that's how I'll wrap it up. Miigwech.
For sharing.
Yeah, thank you.
I think the liver group needs to separate into the other group. I think you're having more time with the kidney group after the break, so I think there could be more discussion at that time. I'm just gonna ask, can you have the online people put them into the breakout room for liver and kidney? And then I'm just gonna ask anyone going to the liver session to go to Scandia 3. And then Candice is now the boss. So Candice will go nuts, whatever this group wants to do.
So for the kidney group, we are right on schedule, so I'm gonna mess it up a little bit. We're gonna take 5 minutes if you need to go to the washroom or if you need, some time for yourself. And we'll come back at 2:35 in this room. Good question. Where's the washroom? Oh, you know where it is?
It's right down the hallway. Just right, left.
Right here. Left, okay. So we'll come back here at 2:35, everybody.
And you're welcome to come closer up, if you feel like you'd like to move forward, you're welcome to as well. So this part of the day, we're going to hear from Andrea Norgate, who's our kidney pancreas coordinator. We're going to hear from Dr. Mucsi, and we're going to hear from Crystal again as well, talking more about her project. Okay. And here is Andrea. I can see her on the screen there. Could you say hello? Let's see if your audio is working.
Hello. Is my audio working?
Hooray, it is.
Look at this. I am so sorry that I'm not there. I am so sorry, but I don't know if I'm starting to dislike Air Canada as much as I dislike the post office right now, and just get in line with behind the Rogers, Bell phone companies, post office, and now Air Canada. They changed the flight so that I couldn't get back today, so I couldn't come out there. Anyway, am I good to start?
Yes, I'm going to pass it over to you now, Andrea, and you are welcome to go through your slides and presentation. Thanks so much.
All right, great. Thank you all. And hello, Crystal. Hello. I miss you. And I just wanted to say that acknowledge that Crystal was is one of my favorite patients. And if there's any justice in this world, I imagine that she will change the world forever, and only for the better. And we are all better off with her being in our world and surrounding us. I'm going to talk about diabetes and what I want to get across. There were two things that I was going to talk about, but there's too much to say about both of them. So I'm just going to leave you with my slides for the other one, which are kind of self-explanatory. And I'll give you a piece of advice. If you're going to look at your own labs, try not to, because nothing is important by itself. There's all kinds of things that sort of like are conjoined that are important, that you can't look at one blood item at a time. And I wanted to talk about diabetes specifically because it really is a shared diagnosis, not just the person that actually is diagnosed with diabetes, but with the entire family. And someone else is always experiencing diabetes with you, whether it be type 1 or type 2. And we'll just talk a little bit about the difference between the two, because there's lots of misconceptions about it. First of all, why is glucose bad? Well, it's not necessarily so bad. It's bad in the wrong spot. It's fantastic. It's how we generate energy, and it is carbohydrate. So carbohydrate, if you think about carbohydrate, and carbohydrate isn't bad either, but carbohydrate is glucose, is what it turns into glucose in your gut. And it's the first line of fuel for your body, so it gives you the energy. And we need energy to do what? All things. We need energy to breathe, walk around, sleep, eat, anything. You just need energy, and it belongs inside the cell. And I think you guys can see me. I'm hoping you can. Someone yell out yes or no. Yeah, yay. Okay, good. So it belongs inside the cell. And what insulin does is it opens up the cell, and then the glucose goes in, and then the cell closes, and you use that carbohydrate or glucose as energy. And that is, ta-da, and that's how it works. But if it's not inside the cell, it's on the outside of the cell. And if it's on the outside of the cell, it's a piece of glass, right? So if you think about it as a little grain of sugar, and that little grain of sugar is just sort of whipping through your vascular system. And if it's not protected, on the inside of the cell is a big sort of like balloon, really. Then it's on the outside. And then if you think about a little tiny shard of glass whipping through your vasculature, it's not a disease of your pancreas, it's a disease of your vasculature. So everything with a blood supply, which is everything that we have, gets damaged over a period of time. And the kidney is only trying to help, but it's a bit of a whiner. And so although it sees this glucose as being too high in the bloodstream and not inside the cell, and so it says, we got to get rid of this. And it starts putting out more urine and more glucose in the urine. And then you get thirsty and then you put more out, and then you get thirsty and then you put more out. And it's only trying to help. But like anything, that overworking gets worn down. And the complications of diabetes are everything, because everything has a blood supply. So it's the leading cause of blindness under the age of 40, because your eyes have a very, very small blood supply. Neuropathy, so that, remember when you went skating when you were little, and then you came back inside and you took your skates off and your feet were so frozen, and when they thawed out, they had that tingling in them. That's what neuropathy feels like. But imagine that times 10, like lots of pain, like it hurts actually when they thaw out. Nephropathy, disease of the kidney. Cardiomyopathy, because your heart has a blood supply. Hypertension, low sugars, decreased quality of life. Neuropathy, gastroparesis, high cholesterol, erectile dysfunction, depression, amputation, stigma, and then the ultimate complication would be death. So you can see that diabetes causes all of these things for everyone, and it's sometimes it happens in a couple decades, sometimes it happens in 1 decade, sometimes it happens in 5 decades, but there's usually a smattering of these things with all diagnoses of diabetes. And so why is the kidney so involved? Well, it tries to remove that excess glucose that's not inside the cell, because you're not having enough insulin or no insulin, through the urine. And so you lose the fluid, you drink more, and the cycle continues. So it's overworked, underpaid, until it just generally quits after a period of time. And that's when we go into kidney disease. And you'll know that you don't have signs and symptoms of kidney disease until you're at less than 30%. So I don't know about you, but the average person doesn't necessarily go to the doctor every year. And so usually coming down with kidney disease is usually a surprise to most people. And the risk factors, so every vascular bed in our body has a different risk factor, right? So the number one risk factor for stroke is hypertension, high blood pressure. And the number one risk factor for cardiac disease is high cholesterol. And the number one risk factor for kidney disease is high sugars. And for peripheral vascular disease, so like amputations or ulcers that just aren't healing, is smoking. And diabetes, guess what it causes? It causes hypertension. It causes heart disease. It causes hyperlipidemia. It causes hyperglycemia. And usually people will smoke at one time in their life because they're told, not only are you a diabetic, but you're a bad diabetic. And they go, screw this. I'm just going to make some bad decisions. And they start doing things that are going to sort of be a detriment to their health on purpose, because you know how bad news travels with the brain. You hold on to them, and you sort of like internalize that bad news, and you just do things to self-destruct. And we all do it. And it's just a matter of time before it sort of catches up with you when you have diabetes. And so type 1 diabetes is bad luck. It's also autoimmune. And what happens with this is that it's an autoimmune disease, and it was first described in the Egyptian tombs, so like 1500 BC. And in the papyrus, if you sort of translate it out, what you'll see is that it describes these sort of melting children. They lose weight, they just pee all the time, and it was type 1 diabetes. So it's been around since the beginning of time, since anyone decided to write anything down. And it wasn't actually named until 180 AD, which is still a while ago, by a physician called Eritreus. And Eritreus actually called it, what they knew is that the kidneys made urine. They did know that in 180 AD. Now, their method of diagnosing is a little off, but it's 180 AD. And so what he decided to do is how he saw these children, they were peeing and they were losing weight and they were thirsty. And what happened, he called it diabetes, which means siphon. And mellitus means sweet. So it actually means sweet siphon in Latin, because he drank the urine of these children, and like as compared to everyone else's, it was actually quite delicious. So therein lies that, because it was full of sugar. And nobody thought to change the name. And so what happens, it's an autoimmune disease. And so something happens in your life, and 0.6% of the population is born with this predisposition. They have 0.6%, and that's it. So it is bad luck. And usually people with type 1 diabetes are parachuted into a family. Nobody knows what they're doing. And everyone's like, oh, what do we do? And the child sort of becomes an adult the minute they're diagnosed. And it's just sort of like, well, good luck to you. It's sort of like, feel it out, see how that goes for you. And it's a terrible affliction to be actually sort of responsible for the function of a major organ system in our body. But that's what happens. So something happens to the child, an incident. It could be a virus. It could be a club on the head. It could be a workplace accident. It could be all kinds of things. But something major has to happen to you, and that triggers an autoimmune response, and you make anti-islet cell antibodies after that, and you destroy all of your own islet cells over a course of sometimes 2 months and sometimes 2 years. And therein, and after that, you don't have any more islet cells. And so you do not make insulin anymore. And from that moment on, you are dependent on exogenous insulin. And exogenous insulin is just injectable insulin. Endogenous means something that you're making yourself. And so everybody died because you had no ability to process your carbohydrate. And so everyone looked like this kid. So they would, so if you're not going to use your carbohydrate as energy, then your body will use up all the energy that it can, all the carbohydrate that's there. And then it says, well, I don't see any more supply, because you're not getting your glucose into your cell. I don't see any more supply. Let's work to the fat. So let's burn down fat. Now we're going to burn down fat in order to get our energy. And then when it runs out of fat, it starts burning down you. So it starts burning down your proteins in order to get some energy, and that's just to stay alive. This is an inefficient system, and you die from it because you can't burn down your proteins in order to get well. And so what everybody needed was insulin, and the discovery of insulin happened in Toronto, and this is like the old Mars building. Actually, it's the front of the building that we actually are attached to, and just because I'm feeling people channel me, I'm sure you've all, like, I can see the audience. Has everyone heard of Banting and Best? Nod. Yes. Yes. Well, it wasn't them. It was Banting and MacLeod got the Nobel Prize. And Banting was a surgeon, but he was working in MacLeod's lab. And MacLeod was he had the lab at U of T. And Best was a medical student, and he was just cleaning out beakers in the lab. That's what I think. And so anyway, when they discovered insulin, Banting discovered this insulin, but it kept killing everybody. So that was no good. And so MacLeod said, hey, I got this really smart guy. His name is Collip. And Collip was doing a PhD with MacLeod, and he was a supervisor. And Collip went on to develop, within 6 weeks, the old beef and pork insulin that I used in my career. And you've never heard of Collip, but he was the one that discovered insulin. So what happened is that Banting and MacLeod, they won the Nobel Prize, and they hated each other. And then they both died within a year of each other. It was, what a time to be alive, was in like 1920s. And one of them was in a plane, and the other one died of consumption. I think it was MacLeod died of consumption, and Banting was in a plane crash. And they died within a year of each other, very shortly after they won the Nobel Prize. And they sold the patent for $1 so that no one would ever make any money on insulin. So if you're on insulin, you know that didn't work out very well. After they both died, Best just took every interview there ever was and never mentioned Collip. And so there's many books about this now, but it's just one of those things that you don't really recognize the person that actually, and it's even a fuzzy picture of him. It's kind of not fair. But anyway, that's clearing the air about the discovery of insulin. I think that that's interesting. And everyone looked like this. So they really thought it was a cure for type 1 diabetes, because this, you can see that this girl, she was not able to process her carbohydrate. And then after she had some insulin, she could process it because it was a means to put that glucose inside the cell where it belongs. Now, type 2 diabetes is something that we can blame our parents for, or blame your ethnicity. It's not really that fair, but it's absolutely true. It is a hereditary disease, not type 1. Type 1 is not hereditary, it's autoimmune disease. Type 2 is hereditary. And so if both of your parents have type 2 diabetes, chances are pretty good that you are going to develop it over a period of time. And what that is, it's an incident of insulin resistance. And so what happens is that you've got your cell and your pancreas is making the right amount of insulin for your glucose. And then your cell's like, no, I'm not opening up. I am not opening up at all. And then you need medications to try and open that up a little bit. And eventually people will need insulin in order to overwhelm that insulin resistance. So if you have an insulin resistance, it only makes sense that you would need more insulin in order to open up that cell. And the risk factors for it are all the things that we love to sort of talk about, is weight. Yay, everyone loves talking about weight, not doing anything. Family history, of course, people over the age of 45 are more at risk of the people under the age of 45, race and ethnicity. I mean, I have a girlfriend who is Filipino, who is she's not obese, she's not inactive, but she is an insulin resistance, a huge insulin resistance. And so Black, Asian, I guess that would be the Filipino, Indigenous, Latino, either Caribbean or African descent. And that's a little bit of a drag too. And of course, gestational diabetes, if you have gestational diabetes, your risk of developing type 2 diabetes is a huge factor, which would be 15 to 70% later on in life. And usually the reason that people who are a little bit overweight will develop type 2 diabetes is because there's more of them, and so they need more insulin. You just need a more insulin demand, because the insulin demands on someone, an average person, is 0.75 units of insulin per kilo per day. So for argument's sake, if you were 100 kilos, you should be on between 60 and 80 units in a 24-hour period of insulin. And the way that a unit of insulin was discovered is that 1 unit of insulin is enough to kill a rabbit, which is, again, I think is interesting. And why are so many people getting diabetes? Well, everyone's blaming everything. And there's 2 countries that are currently in competition for the most people with type 2 diabetes. And one is the United States, because there's more of them, right? Everybody gets my drift. And the other one is India. And India is because they are adapting a diet that is not a traditional Indian diet. And the Indian population are natural vasculopaths. So we're all made a little bit differently. We are all a little bit different depending on where your heritage is from. So if you are Indian, you have a very small vasculature, and so you're called a vasculopath. And if you had a traditional Indian diet and a traditional Indian lifestyle, which would be like mostly agriculture, if you need something, you don't get in the car, you walk to the place, a lot of outside walking, a lot of activity. It's not an obese population, and you would live to your 125. But as soon as you start adapting more of a Western diet, meaning that if you have a third of your plate is a meat, and then a third of your plate is a potato, and then another third of your plate as like maybe another starch like a corn or something like that, that's when you're seeing such an uptick in type 2 diabetes within the entire country. And the prediction from one Indian cardiac surgeon I know is that by 2040, almost 30% of India will have type 2 diabetes, which is incredible amount of people. It's 1 billion people. And the incidence, everyone's blaming food and inactivity. And of course that has something to do with it, but a lot of it has to do with sort of not eating for your, like how you should be eating. You shouldn't be overeating. Everyone shouldn't be under eating too. There's sort of like a natural process. You should eat food, mostly plants, not too much, and try and move. And that's it. You don't have to run. You don't have to, certainly to God, we don't need to run anywhere, but we should be, moving around as much as you can, which is extremely hard when you have kidney disease because you are just exhausted. And the incidence of it in the United States, and this is old data, but it has just gone up. It's on the same ramp for type 2 diabetes. And they sort of took this in the 80s, but in the 70s, I remember growing up, we ate nothing but processed food. I'm sure that didn't help either. And it's a major problem. It's more than 6% of the population. It's actually about almost 11% of the entire population of the world. And it is now competing with cancer, which is a very expensive disease, all cancers, as one of the most expensive diseases for any kind of health system at all. And it's an economic tsunami, like I said. It's a ton of money. And so when we look at things, type 2 diabetes is an insulin resistance. You still make insulin. Type 1 insulin, I don't make any insulin at all. And so the reason that it requires so much such a burden is that insulin, or your brain works on two things. And one of the things that your brain works on is oxygen, right? And the second thing is glucose. But we want people to run their sugars as close to normal as we possibly can in order to avoid those shards of glass sort of like bombarding different organs. But when you run your sugar very close to sort of like 4 or 3.5 or 4, you run the risk of getting a low sugar, which will affect the way your brain works. And a low sugar is terrifying, which is why people, when they have diabetes and have a low sugar, they are in a complete panic. And we don't give enough credence to what a low sugar really feels like. So I would advise this. If you're ever sort of like, trying to explain it to someone, you can actually give the example of if you put a plastic bag over someone's head and tighten it at the neck. Don't do that, but and you tighten it at the neck. Very shortly, that person will become very agitated, will become sweaty, could become violent, could become like confused, any realm of things. And we give credit to that because we understand what not having oxygen is, but that is the same thing that happens when you have a low sugar. And a low sugar is life-threatening, just like no oxygen to the brain is life-threatening. And so when people run their sugars a little bit higher when they have diabetes, it's because they have to live their life and they can't afford to black out if they're driving, or black out when they're walking or looking after their children, or any of these things. And low sugar is a terrifying consequence of diabetes itself. And it's what terrifies me, and it terrifies anyone with diabetes. And there is a caregiver burden in this involved in type 1 or type 2 or type 1 diabetes, because very soon the closest person to the patient knows what a low sugar is, what the signs of a low sugar are, even when that patient themselves can't identify it themselves. And they know what a high sugar is too. And there's mood changes with that too, right? If you're always fluctuating with like low sugars, high sugars, just like, let's say menopause too, and you're fluctuating with mood changes, you become irritating and irritated, and that's not very fun to be with. And there's an irritability that goes along with that. And then there's the restrictions, and then there's and then topple on top of that kidney disease, and you've got dietary restrictions, fluid restrictions, you've got mood changes, you've got low sugars, high sugars, you've got irritability, irritating, nobody's happy to be around. And then you put on top of that sleep. Now, who is sleeping well when they're on peritoneal dialysis? I'm venturing to say not many people. If you're on home hemo, there's always the alarms. And when you have diabetes, there's also the alarms of your glucose. And you can get alarm fatigue. fatigue. And so many people, after a period of time, they're just like, you know what, tonight we're turning it off. And then there's a risk of that. And then there's that tension of whether or not who's going to know what your sugar is. And you can understand this if you have diabetes or if you know someone with diabetes, but it is one of those diseases that everyone is very open to providing you with false advice about. Does that, I don't know if anyone has diabetes, they can tell you that everyone will give them free advice all the time. And I've heard anything but you should have more cinnamon and you would have never had diabetes in the first place. I've heard that, oh, you probably got it from the COVID vaccine. I've heard that you probably got it from, did you drink a lot of Coke when you were a kid? None of that is actually true. And you can educate people to a certain point, and pretty soon my patients just become super good at ignoring people. Does that make sense to everybody? And I think that's it for that presentation. Does anyone have any questions about diabetes?
Thank you, Andrea. I always love listening to you because you also make me laugh. So I feel like I learned something and I laugh whenever I listen to you. So thank you so much for this presentation. And she did mention too that she has another piece on labs, and I have that presentation. So I'm going to send that to everybody as well. So you're going to have the PDF of that.
Yeah.
Does anybody have questions right now for Andrea? We will have time at the end of all of our speakers too to just sit and chat, and we'll keep Andrea with us for the end as well if she's available.
Absolutely. Yeah.
Wonderful. Okay, if we don't have any questions right now, we will move along to Dr. Mucsi. If you could come up, that would be fantastic.
Good afternoon, everybody, both here and online. I'm Istvan Mucsi. I'm a transplant nephrologist in Toronto. And well, thank you for this event. Thank you for coming, and thank you for everybody who shared their experiences. It is very hard, I think. We don't really think, and especially for me being a clinician and being lucky enough to be healthy. And I see patients coming to the clinic most of the time, or see in the hospital, but even in the hospital, I usually see them very briefly. But if you have a condition, you live with that condition all the time, 24/7, and that is scary, and that is hard. And no matter how much you hear about it or try to understand, you can't really know enough of it. And so I think that's something that I'm reminded of here today, and I'm very grateful for that. And I need to try to integrate it in how I work. So today we will be talking about kidney transplant briefly, and that's another thing, that this is not a very easy to understand topic. It's complicated, and especially if you're in it, you never know enough of it. And one important kind of message at the beginning: think about it when you can, and ask questions all the time, and repeatedly, because you need to know as much as you can about having a kidney transplant if you need it, and keeping that long enough to help you live the life and achieve your goals. So before we go to the kidney transplant, and also because this is so complicated, it's a brief presentation. I probably will go over time. Just shut me down whenever it's too much. But I'm here around, and let's talk about it. If you have questions, let's just get to the details. Go back to it again if needs to be. So first, it's important to think about what the kidney is. That's just as Andrea told us about the sugar and how that goes, both to understand what kind of a condition this is, and kidney disease, And also, what can we do to keep the kidneys going if we know that we may be having kidney disease? And if we had a transplant, also it's important to keep everything what we'll be talking about close to our heart, because that helps the kidney going long. So the kidney is an important organ, of course, for a nephrologist. It's the most important pair of organs. It cleans your blood. It does a lot of things that keeps the body healthy and strong. It maintains the composition of the blood and the fluid around. Our body is 60% fluid. And so if it's in imbalance, then we will be very sick. It helps blood pressure control. It helps bone health maintained. It helps the bone marrow to produce blood. So the kidney does a lot of things other than cleaning the blood and producing urine. So obviously when the kidney is getting weak, there's a lot of issues that happen deep inside the body. What is important about this, though, that as it was mentioned already, you don't feel it. You don't feel it until it's very, very late. Most of the time, the kidney function is 70%, 80% of the kidney function is lost before you start to feel sick. And also, it's not pain around the kidney so that you would know. It's just you feeling tired. You feel nauseated. So it's important to keep this in mind, because this is how we need to think about the risk or the kidney disease. It's not when it's there already, it's too late. Still, a lot can be done when we know that we have kidney disease and the kidneys are weak. But what we need to do is to try to not go there. And one way of doing that is if we are aware of who is at risk, who can have it. And so if you know that, you may try to do things to avoid it. And these are the most frequent, Andrea was also already mentioned this, most frequent risk factors for kidney disease. So if you have diabetes, your risk of having kidney disease is much higher than if you don't. If you have high blood pressure, the risk is much higher. If you're overweight, if you're too much of you, that's not good, because then the kidneys have to work harder. As Andrea mentioned, for diabetes, if you have kidney disease in the family, it's a risk factor. Importantly, increasingly recognized, if you're First Nations or Indigenous, and if you're coming from African, Caribbean, and Black communities, your risk of kidney disease is at least 2 to 4-fold higher than for people from European descent who are white. And so what it means is that if you have these risk factors, you don't wait for the symptoms to come, but you try to actively avoid issues that can damage the kidney and look for the kidney disease. We don't usually look for trouble. But in this case, it's important for us to look for the kidney disease, try to identify early. You need to do blood work and urine tests. No other way of understanding if the kidney is not fully healthy. So if you have all the risk factors or any of those risk factors that I mentioned above, you should be tested, especially if you reach the age of 40, 50 years of age. Your kidney function should be tested regularly, maybe once a year. So when you see your doctor, when you think you're healthy, but you have your annual physical, if you're lucky enough to have a family doctor or a nurse practitioner, you need to ask for blood work and urine test. Both is necessary. Urine abnormalities, protein in the urine is the first sign. And that number in the blood work, the creatinine, when it's getting higher, that's the other sign of kidney disease. So you need to do that so that you can slow down the worsening of the kidney function or prevent. So what keeps the kidney happy? It's pretty much what keeps our body happy at all. Importantly, physical activity, moving. You then don't need to be an Olympian. You don't need to run a marathon necessarily, but moving with the dog, working in the garden, even shoveling snow, which is not always fun, but that is what makes your body work, it helps your heart, it helps your kidney healthy. So whatever types of activity you like, you should be doing it regularly. And sometimes even if you don't like it, you need to just to keep going. Food, we spoke a lot about food here. Food is critical for everything. Of course, food is, we also eat because we like the food. And sometimes what we like is not necessarily healthiest. I'm Hungarian, and Hungarian food is not healthy. And I like Hungarian food, and I do eat it. So we had not low salt cookies. I don't know if low salt cookies are good, but usually higher salt cookies are better. So sometimes one can have that thing, but in general, we should try to eat well, meaning lots of fruits and vegetables, a little meat, and a little other things. And this is also important, what has been brought up repeatedly, that unfortunately healthy food is expensive. And this is, the social worker cannot write a check, the physician cannot write a prescription for healthy food, because that's not how it works. You have to pay for it, and not everybody can pay. And that's why health is not equally distributed, and kidney health is not equally distributed. That's one of the reasons why people from different communities and people who are not as well off have a higher risk for kidney disease, because they cannot afford healthy food. But it's important to try, and important to work towards that goal. So what happens if you have kidney disease? And if you have kidney disease at the stage when you need urgent dialysis, this is not relevant. But another reason to identify kidney disease early is that increasingly we have a lot of medications and a lot of things that we spoke about: physical activity, healthy eating, drinking a lot of liquid, controlling blood pressure, that we can do to slow down. Because once you have kidney disease, the kidney function gets weaker, and eventually you get to that 10-15% of kidney function when you need dialysis or transplant. But if you realize here that your kidney function is only 60%, you can still do a lot of things to change this slope and make the decline of the kidney function slower. And then you can maybe avoid the need for transplant or dialysis, but maybe push it out by years. So dialysis, we heard about, is cleaning the blood. It's a life-saving treatment. It's a life-sustaining treatment. It's not easy. It's not fun. And it only provides about 5-10% of kidney function compared to transplant, which provides 60-100% of kidney function. And it's a lot of work doing dialysis. It's a lot of work you need to do, as it was mentioned, either during the night and every night at home if you do peritoneal dialysis, or during the day several times, or you need to go to the dialysis unit several times a week, spend there 3, 4, 5 hours, feel bad, feel tired. It keeps you going, but it is a lot of work, and it's still not a perfect treatment. What is a transplant? It's a surgery, and usually what happens is that you have a third kidney. You get a healthy kidney because your own kidneys are diseased, and the third kidney goes in front of your belly, just under the skin, and that kidney eventually will take over. And although you will have 3 kidneys in the body most of the time, only this one is the one that is really working. If your kidney worked at a few percent initially, they still keep on going for a little while after transplant, but really the transplant kidney is which takes over. And it's only one, so it has to work harder, but it shows you that with one kidney, you can have perfect kidney function. Not everybody after transplant, as Crystal mentioned, her kidney function was not 100% after her transplant. And even 25, 35, 40% can be good enough to feel better. But many patients after a kidney transplant have 100% kidney function, meaning that one kidney is enough for one person. Meaning, and we talk about this, that living donor kidney transplant is the best treatment for kidney failure. Healthy people have 2 kidneys, and they can give up one because the remaining one will most likely be good enough to support them for the rest of their life. I don't go over, but we spoke about this. Transplant is a better treatment, less work, and much better kidney function, better quality of life, and longer life for most people. When you're 65 or older, we don't think that your life will be much longer with a transplant compared to staying on dialysis, but still you will feel much better for most of the time. If you're young, getting a transplant means sometimes tens of years of longer life and healthier life. But of course, transplant is a surgery. You need to take medications for the rest of your life or until the transplant works. It doesn't last forever. And you need to wait for the transplant to become available. Now, we spoke a bit about this already. There are two types of transplant, living donor and deceased donor transplant. And it's important to know that when you're on the waiting list and getting a kidney transplant from the waiting list, most of the time it is coming from a deceased person. It's a person who is dying or died at the hospital in an ICU. And after they died, the organs are retrieved and transported to the transplant hospitals and transplanted. In this case, you don't need to worry about finding the donor. TGLN, Trillium Gift of Life in Ontario, will find you the donor and they will give you the call. But it is not quite as good as a living donor transplant. It lasts around 10, 14 years on average, whereas a living donor transplant can last 18 years on average or longer. It works more quickly and comes with less complication if you have a living donor transplant. Plus, as you know, if you're waiting for a kidney or if you're on dialysis, the waiting time for a kidney transplant, if you're waiting for a deceased donor transplant, can be 4 to 8 years or longer. And that's a lot of time on dialysis when you're not as well as you could be. And that's another advantage of living donor transplant, that it can be available within 4, 6, 8 months after the donor starts their workup, if everything goes well. Importantly, although I'm a transplant nephrologist and I'm saying that a transplant is the best treatment, which I think it is for most patients and not for everybody. There are people who say that they don't want a transplant because they don't feel ready. And again, I think that is an important decision that we need to accept. But even if you have a transplant, even if it's the best treatment, it's not a cure. You need to take medications. You may have complications and you cannot be fully healthy, fully not thinking about your health, but it's as close to being healthy as you can get if you have kidney failure. With transplant, there are side effects. As I said, it's a surgery, so there's a little bit of pain, both for the donor and the recipients. And then you recover. For a recipient, you need about 6, 8, 12 weeks to recover to the level where you start out before transplant or better. And most of the patients will feel significantly better. So the key message is that if you need a kidney transplant, living donor transplant is probably the best option for you. And we spoke a little bit about this, that in First Nations, Indigenous communities, there's so much kidney disease, so many people are affected, or if it's not kidney disease with diabetes, that they cannot donate. So that is an important question for societal solidarity. Can people from other communities step up? And we talk about who can be a donor, and pretty much anyone can be a donor, if you have it. So where can you get a living donor from? At the Toronto General, we do about 200, 220 kidney transplant a year. Close to half of that is coming from living donors, and about half of all the living donor transplants are coming from family, close family or more distant. And the other half is really anyone. Sometimes those are friends, co-workers, neighbors, and sometimes are people whom you may not know. And sometimes it happens that you went to school with someone and then you posted on social media that you need a transplant and they come forward. Because no matter how bad the world looks like, sometimes people want to help. Many people want to help, and it's important to take advantage, because sometimes what we see is that people who have kidney disease, and they may have someone offering a kidney, and they may not want to accept it because they don't want to harm the donor or for other reasons. And that's another important issue, because most of us would be happy to ask a neighbor or a friend to drive us down to the hospital, and driving, especially around Toronto, is extremely dangerous. But we ask the friend and the neighbor to give us a ride. We don't think about that. We, both him and us could die in the ride. But we don't want to ask a person to potentially give a kidney to us, because we don't want to harm them. And kidney transplant and donating a kidney is much safer, actually, after all the workup, than driving on a highway. So many patients who are waiting for a transplant, they are getting frustrated. And I think that came up, that a health journey is frustrating, get frustrated with the workup process. We need to do a lot of testing, and this is the kind of list of tests: blood tests, x-rays, heart tests, seeing specialists, doing a colonoscopy, all that thing that we need to do. Most of the testing is done locally, and especially here it is done in Thunder Bay. And sometime at the end of this, you need to see the nephrologist, you need to see the surgeon, you need to see some specialist, which is organized by the transplant center. Luckily, with the virtual technology, you don't necessarily need to be seen in person. You don't necessarily need to come to the Toronto General Hospital to be seen to get on the list, but sometimes it is necessary. But all this test needs to be done, and it is really for three main reasons. One, we do this testing to make the transplant as safe as possible for everybody. We need to make sure that you don't have any infections hiding in your body, because if you do, those infections can spread and kill you after transplant. Similarly, for cancer, if you have a small cancer hiding somewhere, we need to try to find it before the transplant and take care of it, because after transplant, with the medications that you need to take, cancer would spread very quickly, and it would be much worse than taking care of it before. So that's why we are doing all the testing, and we need to make sure that your heart and lung is strong enough to undergo the surgery. And that's why you need to repeat those testing as well. And we heard about what's happening at the time of the transplant and soon after. The way it goes, you're on the list. And it's important to know that you're not on the list automatically when you start dialysis. You get on the list once you completed this transplant workup, and you did all the testing and you saw the specialist, and eventually you have the green light to be on the list. Importantly, you're not wasting the time before, because in Ontario, your waiting time starts at the time of starting dialysis. So even if it takes you two or 3 years to get on the transplant list, the time counts even before. At the same time, it's important to start it as early as possible, do as quickly as possible, and ideally look for a living donor even before you need to start dialysis, because you can get a transplant even before. Once your kidney function is at or below 15%, you can be transplanted even if you're not on dialysis. So when you're on the list, you are waiting for the call, and the call can come at any time. It could come at noon or at midnight. And sometimes we have time to say, okay, come in tomorrow morning. And sometimes what's happened to Leona or Crystal, they said, okay, come in right away, go to the airport. And so that's important, and it is scary, it is frightening, even if you're coming from next door to Toronto General. Even if I have kids, luckily I didn't have to go to healthcare too much, but whenever we had to go with the kids, it was scary, even for me. It was frustrating frequently, even for me. And so if you're coming from a different city, if you're coming from a place where you don't know what's happening, it is very scary. And then there was mentioning about the false alarms, that we sometimes call you in and we don't have a kidney at the end. you have a surgery which is about 3 hours long. It's not a major surgery to have a kidney transplant. And usually you stay in the hospital for 4 or 5 days and may go home after. And usually for people who are coming from Thunder Bay, we ask them to stay around as long as it's needed to have the surgical issues cleared up, which may take 3 to 6 weeks on average. When you go home, initially in the first few weeks, we want you to do blood work twice every week. And initially it needs to be in our hospital, so we get the results quickly. Later on, it's much less frequent. And after about a year, you do blood work every 3 months so that we can still keep an eye on that kidney function. And then we would see you every 6 to 12 months in the clinic, either in person or virtually. So it's much less than going to the hospital for the dialysis 3 times a week. And you don't need to worry about food as much as you need to when you're on dialysis. You don't need to worry about fluids, as Krishna mentioned. The dialysis is not always that successful or easy to remove the fluids. When you have a transplanted kidney, the kidney is smart and it takes care of most of all those things. For about 2 or 3 weeks, you cannot drive. And as I said, the recovery takes a few months, couple of months, but then gradually you will return to everything that you had been doing and more. And after transplant, after 2 or 3 months, you can pretty much return to anything that you want. We don't suggest doing contact sports, but otherwise everything is on the table and you can go back to work, you can go back to school, you can travel, you can look after your grandchildren, you can do whatever you need to do in your life. So I think I finish here. This is the Toronto General Hospital. It's a huge institution. It takes up a whole block between College and Gerrard Street and Elizabeth and University. It's a good facility, and we do a lot of transplant. This is the list of all the transplant that we do every year. Importantly, we do kidney, pancreas, liver, heart, and lung transplant. And this is a big hospital. We do a lot of kidney transplant. Our surgeons are really excellent. And we try to be good, but as it was mentioned, sometimes our healthcare system is not really doing what it's supposed to. We are people in the healthcare system that we bring in our biases, and sometimes we don't really behave as well. Leona mentioned that she was marked as a behavior patient because she was talking. Well, I think we should have a system to mark the doctors also and the nurses when they are behavioral, because we are sometimes, and maybe even unfortunately more frequently than we should be. So I'm here, and then if you have questions, I'm happy to answer and happy to just chat around as we go. Thank you for your attention. Yes?
How do you access your information?
This one that I showed?
Yeah.
It will be sent around as a PDF. Also, the session is recorded, and hopefully it will be on the website, and maybe I'll send it on the website. But the slide will be available. Candice, how are we sending this out?
The slides?
Yes.
So if you registered with an email, it'll be sent to that email. Yeah, all of the slides, so you'll get all of Dr. Mucci's slides as well.
If you need, I can do it from my computer. Yes, that's nice.
Which one right now, when I need to know exactly what I'm facing, we chose one. How dare you put that? I'm putting I should keep my fingers crossed for me. That's not the lesson. The information there you presented is something that I need to.
Absolutely, as I said, we need to ask, and it's complicated. Also, sometimes we change what we do. But the team here, we're working very closely together. You can ask the nurses and the unit, you can ask the team, you can ask the educators. If they don't know, they can ask us and we can relay the information. I also, at the end, and also I think one of you mentioned that decisions are made in Toronto and we never show our faces here. I'm here for the first time, and hopefully not the last time. So we can talk about it. I get my information from Kimberly. It's a good source of information, so absolutely. Yeah. But again, sometimes we don't communicate well, and they may think that something that doesn't stop. It's important to ask and ask again and ask again. And this is important. So whenever it's important for your life, you shouldn't stop and you shouldn't just assume that things are boring. If you don't hear from the street, ask them. Okay, so I did that. That's what's happening. What is next time? You don't hear, because sometimes it seeps you less. I know that whenever people faxing, the faxes were sitting for months on the desk because there is not enough people to present them. But if you ask them, then it will be. Unfortunately, you need to family that you and your family need to be your advocate. You need to go up, you need to remind us, you need to ask us, and hopefully you can move. And of course, those tasks need to be done. And also, I will say that while you're waiting, those tasks need to be repeated to make sure that they are still enough. But if there's any, I'm going to be around, so if there's any question after, I'm happy to continue.
We're just pulling up some slides, so we'll just do a second.
Check an online question.
The any online question was more Dr. Mucsi or info.
Okay, so now we're going to have Crystal come up and talk about the Indigenous Kidney Health Project. And hopefully the slides come through. Awesome.
I would have to do this so I can see my script at the same time. Okay. Oops, is that really loud? It's hard for me to see at this level, but one sec. Can I get maybe someone to switch this, change the slides while I'm doing it?
Do you want me to click next slide?
Yeah, sure.
Yeah.
Okay. I gotta figure out where to. Unfortunately, so sorry, just give me a minute here. I gotta see where I can see. Okay. This seems to be the best height, I think, that I'm gonna get. And I just want to apologize again for not being more prepared. I didn't really have the time. And like I said, dialysis ate up a lot of my productivity the last couple of weeks. Can you all hear me okay? Yeah. Okay. And do you have the slide thing? Perfect. Okay. Okay, so good morning, everyone. Nanim Bushu, Minagijagan, Sagabanakwa, Dishnakas, Makwandodem, Vichrovixavi, Nishandakindoji. And so that's just my way of grounding to the community, to my community, to my lands, to my culture. It's like an important way to start out any presentation I do. So I'm doing it again, even though I just said it's on my way of introducing myself. And so my name is Crystal Hardy. And in my language, what I said is, hello, good afternoon. My name is Crystal Hardy, and I come from Rocky Bay First Nation. My spirit name is Rising Sun Woman. So I'm honored to be here today to present to you present on the Indigenous Kidney Health Project, which is a collaborative initiative that broadly encompasses my doctoral internship as well as my dissertation work. And hopefully we'll expand out beyond that, the scope of that. And so it brings together First Nations communities, leadership, and patient partners with care providers, nephrologists, nurses, social workers, pre- and post-transplant coordinators, as well as academic researchers to strengthen equity across the renal care continuum for First Nations patients, renal patients. And so this project is co-developed, as I mentioned, by Dr. Mucsi, Dr. Istvan Mucsi, whose leadership in nephrology and transplantation has been integral in shaping this initiative. Next slide, please. And so why this matters. Across Canada, we continue to see a clear and persistent disparity in kidney health outcomes for First Nations peoples. Chronic kidney disease and end-stage kidney disease occur 2 to 3 times more frequently among First Nations peoples compared to non-Indigenous, as Dr. Mucsi mentioned just a minute ago. In some northern regions, transplant referrals are reported to be as low as 7 times less than their non-Indigenous population. And so these numbers really represent far more than statistics. They reflect lived experiences of delayed diagnoses, limited access to nephrology services, and the need to relocate far from home for treatments and transplantation. And so for Indigenous peoples, the journey to dialysis or transplant often means leaving family, culture, and community supports, leaving everyone behind. And so transplantation is the gold standard, as Dr. Mucsi said, for both survival and quality of life in kidney failure. It offers not only extended lifespan, but also the potential for return to work, parenting, and community life. And so when access is this inequitable, the consequences ripple across entire families and nations. And so the Indigenous Kidney Health Project was really created in response to these inequities, and sort of some of the experiential pieces that I pulled out from my own journey across the care continuum, and then speaking with other partners in that process. And so it combines research, community engagement, and system-led partnerships to address both the academic, medical, and social dimensions of kidney health. So rather than framing this as a failure of individual behavior or of health systems alone, our approach is to focus on building partnerships that bring knowledge systems, both Indigenous and biomedical, together, and that emphasize shared accountability as well as relational care. Next slide, please, Candice. Thank you. The gap across Ontario. So when we look specifically at Ontario, the disparities in kidney care become even more visible. Regional data show striking variation in transplant referral rates with approximately 10 referrals per 100 person years in Northern Ontario compared to nearly 29 per 100 person years in Toronto, the Toronto region. So this means that geography alone can triple a person's likelihood of being referred for a transplant. And in a province as resource-rich as Ontario, that kind of regional inequity really speaks of deeper structural challenges. Indigenous patients are also less likely to receive preemptive or living donor transplants. And these gaps are not about patient motivation or non-compliance, as Leona talked about. They actually reflect real tangible barriers, such as limited access to nephrologists and transplant programs, inconsistent communications between care teams, which is not intentional, but it does happen, and then policies that were not designed with Northern or Indigenous realities in mind. And so what we see is a system that often functions well for those living near larger institutions, but struggles to adapt to rural and remote contexts. So travel distances, fragmented referral pathways, and jurisdictional complexities between provinces and federal systems all contribute to delayed or missed opportunities for timely transplant workup. And so our goal through the development of the Indigenous Kidney Health Project is to identify precisely where those breakdowns occur, and co-design solutions that are grounded in collaboration, relational accountability, and evidence. And so what we'll be doing is bringing First Nations patient partners, community leaders, care providers, and key interest holders together to begin to close the geographic and systemic gaps, not by assigning blame, but by aligning our efforts toward equity and continuity of care, supporting care providers where system gaps emerge, and also facilitating care for First Nations renal patients along the continuum. And I think, you know, I've kind of been talking about Mr. Wapoose a little bit in his experience, but he shared a lot of really important things today. And I think this is Mr. Wapoose, where like your experience is very valuable, and we could use that kind of insight to sort of guide the work that we do and hopefully make these changes to make the system more effective for First Nations people. Next slide, please, Candice. So why these gaps persist? Understanding why these inequities persist requires looking beyond medical indicators. And so the barriers are multi-layered, spanning geography, culture, and history. And they're rooted in systemic conditions that continue to shape access to care today. So geography and relocation remain some of the most pressing challenges for receiving treatment and transplantation. Many Indigenous patients must travel hundreds of kilometers to reach dialysis or transplant center. And this often means leaving their communities, home, and family supports for extended periods of time, if not permanently, which can be emotionally and financially devastating and may even lead to refusal to seek treatment. And so some are forced to relocate indefinitely, like I said, or permanently, which can create deep social disconnection as well as trauma that really no clinical metric is able to capture. And so system navigation is another core issue. Care coordination between local clinics, national renal programs, and transplant centers can be fragmented with unclear or inconsistent referral pathways. And so too often patients and families bear the responsibility of coordinating their own care across multiple jurisdictions and providers. This can result in a bit of a cultural mismatch, which further compounds these logistical barriers. Education materials and communication styles often also reflect Western biomedical norms, which may not align well with Indigenous values, languages, or worldviews. And so without cultural congruence, even well-intentioned care can feel alienating or mistrustful. And so we must also acknowledge historical and structural factors, the enduring impacts of colonization, racism, and jurisdictional gaps between provincial and federal health systems. These aren't abstract forces. They influence how trust is built or broken in every clinical encounter. And so finally, living donor and socioeconomic barriers, including smaller donor pools, financial constraints, and travel costs, which many people have spoken about today. These further widen disparities in transplant access. Addressing these challenges requires more than incremental policy change. It calls for relationship-based systems, a redesign where Indigenous leadership, community navigators, and culturally coherent education become integral parts of the solution. Next slide, please. And so one of the things we do know is that early detection works. And so one of the most prominent areas of transformation in Indigenous kidney health has been the success of community-based early detection programs such as Kidney Check. Kidney Check brings mobile screening and early detection into First Nations, offering on-site testing for A1C, EGFR, and ACR, alongside culturally safe and responsive education and immediate feedback. And so this is a stepping stone to effective relational care. And as a byproduct, if we are able to meet people where they are in their communities, in their homes, then we can start to restore a sense of trust, while also restoring a sense of shared ownership over health and autonomy over health. And so what makes this model distinct is that it's Indigenous-led and co-developed. And the program is guided by OCAP, of course, the OCAP principles of ownership, control, access, and possession, which again embodies relational accountability in practice. So rather than collecting data about a community, it aims to connect knowledge directly with First Nations partners. And so early detection matters profoundly because kidney disease can progress silently for years, as Dr. Mucsi mentioned in his presentation. So when the conditions like diabetes and hypertension are caught early, treatment can delay kidney failure and potential treatments like dialysis and transplantation. So for those already living with kidney disease, timely screening means better management and improves long-term outcomes. Participants in Kidney Check have reported greater trust in healthcare providers, stronger engagement with follow-up care, and renewed motivation to protect their health. And so these outcomes reflect more than improved clinical indicators. They signify the rebuilding of relationships between communities and care systems. And so this model demonstrates what's feasible or possible rather when Indigenous governments, scientific innovation, and community partnership come together. And I think this serves as a living example of what is possible with two-eyed seeing. And so that's drawing from the strengths of the Indigenous and the Western knowledge systems to enhance kidney wellness. Next slide, please. And now we get to the Indigenous Kidney Health Project. So the Indigenous Kidney Health Project is both a research initiative and a relationship-based journey. It broadly encompasses the work of my doctoral internship and my dissertation, as I said. And so we plan to build this project out from those two complementary but distinct components. And so the first encompasses work completed during my internship, which was to map the landscape of kidney care for Indigenous renal patients across the care continuum. And so that's from early diagnosis to transplantation. And so through key informant interviews with patients, providers, community leaders, and interest holders, we identified where the system excels and where we could support or enhance the system and care providers. And so this component is still underway, but so far the findings are revealing extraordinary dedication among providers, but also exposing fragmented pathways that could be improved upon. And so, and some systemic gaps as well that leave patients navigating without sufficient guidance. So by exploring the lived experiences of First Nations renal patients, families, and, the dissertation component expands on this internship work by exploring the lived experience of First Nations renal patients, families, and care providers. It uses Indigenous story work to understand how cultural values, trust, and relational continuity influence every step of the care continuum, which we will then pair alongside quantitative medical chart reviews to match clinical outcomes with experiential relevance. And so this means for us listening deeply to stories of resilience and barriers, and identifying solutions that emerge from within communities, not just from policy or clinical perspectives. And so together these streams create a holistic landscape and understanding of the patient journey, illuminating not only the obstacles, but also the strengths that sustain people along the way. And so, as I've mentioned, the work is guided by relational accountability, Indigenous story work, and two-eyed seeing, which collectively ensure that this research is not only extractive, but reciprocal, and that every partnership is more than just a data point, and that every recommendation is grounded in respect, responsibility, and relationality. And so the Indigenous Kidney Health Project is really about restoring continuity, trust, and equity, showing that when Indigenous governance and clinical collaboration intersect, we can improve the kidney care landscape together. That's our hope. And I think maybe we hopefully bridge the first step of that by going to meet with clinical staff and care providers at the Thunder Bay Regional today to bridge maybe a partnership and just become familiar with one another across jurisdictions. Next slide, please, Candice. So this next section, from evidence to action, represents the heart of our work, moving beyond identifying barriers to co-creating meaningful insight and lasting change. And so the Indigenous Kidney Health Project is not just about documenting inequities. We want it to be about transforming evidence into practice through relationships, co-learning, and shared leadership. The first area of transformation is collaborative navigation. And so when Indigenous and clinical evaluators or navigators rather work together, communication improves dramatically. Patients feel seen, heard, and supported, which can dramatically increase or improve outcomes. And so these navigators bridge cultural and systemic bridges or divides, ensuring that information flows bidirectionally, and that patients understand their care journey from screening to referral to transplant readiness. And second, cultural responsive education. So we hope to strengthen trust in decision-making through co-developed learning tools and community sessions that empower patients to make informed choices about treatment modalities and transplant options. So this isn't about simply translating information. It's about aligning health education with values, language, and worldviews. So third, measurement that matters. So we hope to track time to referral, workup completion, and waitlist activation, and disaggregate this data by identity so that we can create accountability mechanisms that guide equitable improvement. And this would allow our renal programs to see where disparities exist and exactly where we can act earlier to correct them. Knowledge mobilization. We hope to ensure that these insights don't sit, in fact, we will ensure that these insights don't sit in reports. And we'll develop workshops, story-based dialogue, and community forums that honor both scientific rigor and lived experiences. Finally, relational implementation, perhaps, and most vital, we want to ensure that every policy and practice choice is rooted in respect, reciprocity, and co-learning, and that it's not enough to act. We are developing this project by acting in relationship. And so by weaving together these layers, navigation, education, measurement, and relational implementation, we hope to move from data points to transformation. Next slide, please. So our next focus is regional, and what this work means to Thunder Bay and the broader Northwest region, where so many of these challenges converge. The Thunder Bay Regional Health Sciences Center, the Ontario Renal Network, and the Ajmera Transplant Center each play essential roles in this work, but true progress requires that we link them through a shared vision and coordinated action. And so first, we're working to strengthen our regional collaboration across renal programs. And this starts with connection across these vast jurisdictions. So just connecting and becoming familiar with one another, I think, is a good first step. This means meeting consistently, referral and evaluation processes, so that a patient in Sioux Lookout, Sachigo Lake First Nation, Fort William First Nation, or anywhere else can experience the same clarity and supports as someone in Toronto when seeking transplant or treatment. And regular cross-site meetings are an important part of this collaboration, as well as joint quality reviews, and shared data systems would really help to close some of these regional gaps. Second, we're aiming to develop stronger support systems for both patients and providers providers need more time, tools, and cultural safety resources to communicate effectively with and care effectively. Patients need clear guidance and support at every step of their transplant journey. And the aim is shared understanding rather than siloed conversations. Third, we plan to advance navigation and relocation supports. And so some of this work is already underway at a very small scale. As we progress, we hope to embed Indigenous navigators who already exist in both the centers, Thunder Bay Regional and the Toronto General Hospital, but maybe kind of tie in some of the or identify some of the gaps where navigators would be really useful in supporting. And so we're going to do that to create, improve relocation pathways and develop relocation pathways with the intent of honoring holistic well-being for patients. And so when relocation is required, it should never mean cultural dislocation. And finally, we plan to expand on kidney check or expand and work with kidney check and food sovereignty initiatives, integrating renal friendly and traditional foods into wellness programming. Nutrition is not only biochemical management, it's about dignity, autonomy, and connection to land and language. And so by grounding the priorities in ownership and respect, Thunder Bay can become a model for relational community driven kidney care. I think Thunder Bay and the Toronto General. So this could be a program where Indigenous leadership and healthcare providers can move forward together. Next slide, please. As we wrap this overview up, I'd like to return to the core idea that guides all of this work, and that is that when governance, navigation, and culturally coherent education align, time to transplant shortens and lives can be saved. And this sentiment really, for me, captures the spirit of the Indigenous Kidney Health Project. It reminds us that change happens not through isolated interventions, but through alignment and between systems and communities, between data and lived experiences, and between intention and accountability. Next slide, please. So before we close, I want to take a quick moment to acknowledge all of those whose wisdom, guidance, and partnership are making this work possible. So firstly, the patient partners and the families who have agreed to share their stories and truths with courage, those who we've spoken with already, and those whom we will hopefully connect with. The elders and community leaders who've already shared so much of their knowledges and time to ground this work in a good way, in ethics of care and respect. The healthcare providers and allied health staff who so kindly welcomed us into their world today, and showed us around the Thunder Bay Regional's renal unit. My mentors and our research partners, most notably Dr. Mucsi, Dr. Istvan Mucsi, Dr. Chris Musquash, Dr. Charles Levko, Dr. Janet Smiley, and Dr. Aminu Bello, as well as the UHN transplant team. And of course, our institutional partners, the UHN Transplant Center, the Thunder Bay Regional Health Sciences Center, Toronto General Hospital, and the Ontario Renal Network, who ensure that this work continues to evolve and reach those who need it. And next slide. Miigwech, that's the Indigenous Kidney Health Project for today. So I don't know, is it on the slide with our emails on it? Oh, yeah, the last slide had our emails on it, yeah. And so I just wanted to leave that up for a minute, because if anyone in the room wanted to be like a patient partner or connect with us, then you can contact us at our emails, and we'd be happy to like speak to you and have you join the project with us.
For a second. In case you can't see
I can't,
that,
yeah.
I'm gonna spell it out for you. So crystals is CNHARDY at lakeheadu.ca. And Dr. Mucci's is ISTVAN.MUCSI@UHN.ca. And again, I will send these slides out too, so you'll have Crystal's slides about this as well. I know we're right at 4 o'clock, so we ended on time, but you're welcome to stay and commune with everybody and chat. And are you okay to take one question? Okay, go ahead, Mr. Wapus. Let me bring you my. Here we go.
It's too bad Kim won't hear what I have to say. She's gone. No, the project there is a good project, but I do have a few comments about it. Like, I mean, I guess first of all is I acknowledge your presentation. Like, it's a good report that I think you're presenting here, but the wording is too fancy. I mean, for university, college people, educated people will understand the terminology that's used there. I certainly understand that as well, the wording that you use. But what about those other people, okay?
Yeah.
That need to consult this report here, eh? It is good, okay? I know my chiefs from Ottawa are looking at some of these activities that go on with these patients, okay? First of all, I know that there's a lot of people coming from the isolated communities, okay, that don't have this this kind of stuff in their clinics. The renal machines and all that stuff. So they have to transition to Thunder Bay, to an urban center. It's a totally different. I know you did address it in the context that, not in a simple context, but, in a educated context, like, somebody to, but like I said, these other people that need to consult that are not really educated, have to understand that report as well, right?
Oh, definitely, yeah.
That's the thing that I'm talking about. And like what I said, the transition, there needs, like our chiefs are starting to look at more of that now than before, to support their members that come in for dialysis. Okay. And whereas, in the past that it was just on your own type of thing, And the other thing that needs to be more illustrated is that is the financial aspect of the income part.
Yeah.
And I think it's very important, you know, for our chiefs to understand that you need a good income in order to have a good meal, per se. You know, not like just buying processed food kind of thing that will deteriorate your health, you know. And I've seen that, you know, and I know that. So those are the things that that needs to be more detailed, I guess. I would suggest that, you know. And the other thing too that I notice is that a lot of these people that transition from the First Nation communities is that the language aspect, they can't really, you know, speak for themselves kind of thing. Not like me, you know. I can speak for myself. You know, the other day I offended the chief of police there with my questions of some of the things. So that's what I mean. I can certainly say these kind of things to the nurses as well. You know, if I deem, like, you know, think that that something is not right. So I know they have Indigenous navigators at the hospital. And I've seen their interpretation, translation. You know, they don't tell exactly what the patient is saying to the nurse or to the manager at the renal when somebody is complaining. Okay? They use soft tone, polite context, you know, not really saying it the right way, the way the patient is saying in his or her own language kind of thing. You know, that's the other thing that needs to be addressed, I believe, in your report that you know, will strengthen the you know, the you know, the issue here, you know, with the patient. So that's the Indigenous navigator stuff, you know, that is there. Now at Matawa, we're looking at our own now, you know, instead of relying on the hospital navigator, Indigenous navigator, you know. To me, that person who is translating is useless. Not the way, you know, you don't say it the way that the patient wants you to say it, kind of thing. Why? Are you afraid? You know, that's the type of thing that I see, witness what's happening there, you know. And the other stuff that you did briefly mention in that line item that you know, a bit is a treatment. Okay. Sometimes, like I said, I've worked in the office environment, and my staff used to do this too. When they talk about something or talk about another stuff, you know, they huddle. And I see that at the Reno department. And every time I see a huddle with the staff, and I ask them, can I join the conference? Once they hear me say that, they split. They go back to work somewhere, wherever they're supposed to, you know? And it's not right. Either you're talking about a management system that you don't like, or you're talking about a patient. You don't know. Or they could even be talking about me. I don't know. Why do they split? You know, it's unprofessional like that when it's happening like that. You know, and it affects, you know, these people that are there relying on service from these people that they're supposed to be providing. You know, that sort of thing. So I created myself a nickname in that Reno department. They call me Trouble, Mr. Trouble. You know, oh, here comes trouble. Well, I don't mind that. I mean, it's only a nickname. So, you know, and I recently went to my friend's funeral, and he was cremated afterwards. And I was telling these nurses there, well, I went to my friend's funeral and he was cremated afterwards. And I tell them, when I die, I'm going to have my family make me into a statue and put me in front of the Reno entrance so you can have memory of me every day when you come to work. You know, that's what I told him. So, I mean, sometimes I work both ways. You know, like I can be joking, you know, or funny, you know, and I could be serious as well, you know, because I've learned this, you know, from my work. So it does affect me at times when why I'm saying this, you know, as a renal patient. And I read all these advertisements, how they're supposed to approach their philosophy and all that, you know, all positive things in there. And when one comes in not following those things, it affects me, you know. I'm a patient of renal, and I've been there for 8 years now, approximately. The only one that I really have a good relationship with is the transplant nurse here, Kim. I've never had to, you know, tell her anything that I don't like of her approach, you know. But others, it's a question mark, you know. I had to say what I had to say, you know, and that sort of thing, you know. And so with that, I think the report there needs a little bit of, if you don't mind, saying that a little bit more work on it, you know, just to, because I'm coming from people that are not really educated to read it, you know. If I was a university professor, that's really good for me, you know, but I'm not a professor either. So I noticed that you already acknowledged the people that were involved. And I did see that patient partners you mentioned there. Was that directly a patient of renal
Yeah, renal patients. So this project is just, we're in the development stage. So it's just starting up. So we're seeking patient partners. We have a few already. But it's First Nation renal patients that are partnering on this project. So
Yeah.
people like you who are living through it, have seen and lived through the trajectory, the journey, the continuum, and can share their experiences about that and put in their feedback about how we should shape this project.
Yeah, that's where you'll get your firsthand information if you talk to those kind of people there.
Yes,
know.
definitely.
I think maybe more of that should be done, rather than just giving you information from the policy per se kind of thing, you know? Like myself, like I said, I've been there for 8 years,
Right.
you know?
Yeah.
And I go through a lot of things that I can talk about, and I'm going to be doing that to our chiefs at Matawa, so that they can understand a little bit more of what goes on at, you know, in this kind of business here, you know? So I think it's good that there's a report there anyway. And is there any way that we can have access to the report?
Yeah, there's no report yet, like we're just developing, but maybe I can come talk to you. And I can give you my email
Yeah,
or my cell number, and then we can connect.
okay,
Sounds good?
yeah.
Okay, let me go ahead.
Because, yeah, like I'm in a good relationship with the Reno manager,
Okay,
you know, that her and I, you know, we talk and we exchange ideas and stuff like that, you know, to try and help her. And she wanted to put me on the board
oh,
there, you know, to be involved, and I don't know if I want to do it at this point, because I want to concentrate on my transplant if I can get to that point there.
yeah,
I'm not there yet, but you know,
yeah,
I need one more appointment that I have to go through
okay, you're
in order
close.
for the doctors to decide whether I'll be on the list or not.
Okay,
Yeah, so anyway, thank you very much.
let me go ahead.
I see we have a hand up for Andrea.
Hello.
Hi, Andrea.
And just to give a break quick before you say that, if anybody needs to leave, you're welcome to as well. I know we're over time. Okay, go ahead, Andrea, and then I'll pass it to.
Hey, sorry. Hi, Crystal. Hi. Sorry, I'm not there with you today. I was just wondering, what would you do about, like, how would you combat when you are trying to transfer an Indigenous person or someone who is from remote communities, fly-in communities back home to their community, and having a little bit of pushback from their like, say, the transplant center or people that would be otherwise looking after them, say like Northern Manitoba, if you want to transfer them back to their actual community, where I think people do better around their family regardless, as opposed to people just wanting them to stay within the area that they receive their dialysis. So they've gone to relocate to dialysis, and then they've done all that, and then when they're finally transplanted, they want them to stay within the community that they had their dialysis in, and that's not the purpose of transplant, in my opinion. So how would you combat that?
Well, I think, yeah, so how we're approaching this is really just to get the information from the community partners. And so what works best for the community partners will kind of drive how we develop those pathways. But we did have a conversation this morning when Dr. Mucsi and I went to the Thunder Bay Regional, and we talked about potentially transitioning some of the pre-testing, for example, and the transplant workup, and formatting it into a 2-day process and having it all done at once so that we can sort of expedite the process for patients from remote regions.
Absolutely.
Maybe we could flip that on its head somehow, as something I can think of off the top of my head, right? And so if we can like, if we can transition some of the care into local hubs, maybe we can kind of expedite that process of getting them home, and there won't be that need for those like the extraction and relocation and all of that stuff. But I think really I can't speak to the specifics of how that would work, because I think like like we heard today, right, every transplant case is very personal and independent and varied, and I think that has to be driven by community partners.
Great, great. Look forward to working with you.
You too, Andrea.
Okay.
Love your story, by the way. Thank you.
I just had a question over here, or it's not really a question. Well, it might be. So I'm the Director of Indigenous Collaborations, Equity and Inclusions at the Norgate Regional Health Sciences Center. And one of the things that we're working on currently is data sovereignty. You did mention OCAP principles for your project. So the other thing is that we do have an Indigenous Partner Steering Committee table that is comprised of various Indigenous organizations regionally, because we do have Silcoat First Nations Health Authority, Matawa Health Co-op, Anishinaabe Aski Nation, and Delico, and yeah, there's like several others that I can't really think of on the spot, but we do have the Indigenous Partner Steering Committee that we do like to update on projects, especially that involve their community members. There's a lot of talk for a few years now from chiefs at their AGMs or chiefs meetings everywhere about data sovereignty. So it is a big topic for that. So my question probably would be like, where would the data be stored? How would it be accessed? Because one of the other things that we do at the hospital now is if a community leadership calls us to ask us for any data, it does belong to them.
Yeah.
Without giving patient information. Usually it's like a group of numbers. Or if it's within their Indigenous organizations, if it comes from a chiefs meeting or something like that. Let's say Silcoat First Nations Health Authority, they have a chiefs meeting comprised of their 35 or 33 chiefs. And they are requesting some other data, so they would come to us, and then we would give them that data.
Yeah.
So that data would also help them with any proposals that they submit to the federal government for, let's say, long-term housing or elders complexes. An idea that I hopefully would see one day is like long-term housing for like renal or cancer patients out here. So it's not, we are currently creating processes for it currently, so I'm not sure if like the renal department is aware of that, but we are working something similarly with cancer care. So that is just my question, like will your research counterpart at UHN be reaching out with their ethics boards with the Lakefed or
Yeah,
Regional to get all that information, and just how would the data be accessed for First Nation communities and leaderships?
Sure, yeah. So first and foremost, we reached out to the First Nations PTOs. So we are partnering with Anishinaabe Aski Nation, Anishinaabe Nation, as well as the Association of Iroquois and Allied Indians. And then we're also going to try to connect with, I'm going to try to connect with the Chiefs of Ontario as well as the patient partners themselves. And then post that, we'll do we'll follow the REB requirements for Lakehead as well as UHN. So it's a rigorous process. And ensuring, and OCAP's tied into all of that. So data sovereignty is very important to us. But I think primarily it's a very iterative process. So even developing the interview guide for the internship key informant interviews was sort of an iterative process built on relational accountability. And so that meant going back and forth with one of our partners, our knowledge keepers, who is a grand chief of one of the PTOs. And so I was grounding that work in a good way. And so we don't have any real control over dissemination or access without their consent. During data collection, I think we haven't gotten that far yet with the medical chart reviews because as I said, we're just developing this project. I have to go through all the ethical requirements before I start my dissertation work, but we're structuring this. And so what I can foresee is that this data has to be stored in a secure location. And the First Nations participants as well as the governing bodies will have access to it and control over it, and also have control over subsequent dissemination materials, publications, so on and so forth, and how we treat that data. And then the other part of that is if any patient partners or PTOs or anyone at any time decides they don't want to be a part of our project, then that's an immediate cutoff of anything they've brought forth into the project, if that's what they wish.
Maybe I can reach you offline.
Yeah, sure. Yeah, for sure.
Sorry, I was just going to say that I can provide the email address for sure. Just because we're already at 4:30, I think we could have a full day of just talking to Crystal. I think everybody would agree. But just for the sake of time for everybody, we're going to call it end now. Thank you to our tech team over there for helping us today. Thank you to Andrea and her lovely puppy for sharing. Thank you so much. And of course, thank you to Dr. Mucsi and to Crystal and to all of you. Again, please feel free to email me back if there's any contacts that you would like me to connect you with. And thank you so much, everybody. Have a wonderful day.
Have to?